वैसा ह्यूज हॉस्पिटल, दोनों का भी, प्रेरणा का,
बाप रे।
प्रशांत का। प्रशांत का तो पैथोलॉजी ऐसा टेरिफिक।
जबरदस्त।
हॉस्पिटल के लिए बहुत बड़ी जगह भी लेके रखी है। और घर तो क्या देखना पड़ता, रहने वाले लोग 3 हैं और घर में टोटल
हम्म।
टोटल एस्टेब्लिशमेंट कम से कम 10-12 लोगों का।
मुझे तो कभी बुलाया नहीं, लेकिन ठीक है, अच्छा है,
बुलाया
आपको
ना,
तो बुलाया।
बुलाया
आपको
तुम
बोला
कान
था
में।
मैंने, आधा
वही,
घूमी और 300 क्या घुमाती हूँ।
कान में उंगली डाल के बैठे थे तुमको मेरे सामने बोला चल करके।
मैंने बोला था, देखो भाई मेरे बारे में कभी नहीं बोलेगा उल्टा, सुनेगा भी नहीं उल्टा और बोलेगा भी नहीं। मदन, मदन मुझे दिन भर खपाता है भाई, कैंपेन के
नहीं,
कैम,
वो
कैंपेन के आड़ में।
ये अभी तो इस बार पूरा प्रेरणा नहीं किया है इससे, ये वेबिनार का मैंने किसी को कॉल भी नहीं किया।
नहीं नहीं, और जैसे चल रहा वैसे चलने दो, तुम दोनों को इलेक्शन लड़ने की जरूरत नहीं पड़ेगी।
हम्म।
अभी मैं जा रहा 7th को इंदौर।
हाँ हाँ,
वो
बोला मुझे, अर्चना मैम ने बताया था।
चल रही है ना।
आप आ रहे हो बोल के।
हाँ।
क्या
और
है 7th को, ये रिच?
रीच रीच प्रोग्राम इंदौर।
हम्म।
हम्म।
देन उसके बाद में अभी एक रायपुर में हुआ, उसमें एडोलेसेंट का ही था बट पॉसिबल नहीं था मुझे जाना। और
हम्म।
देन हम लोग 3-4 को तो हम मिल रहे ना, खजुराहो में,
हाँ,
3rd 4th।
मैं भी जा रही हूँ 7th को, अगरतला रीच है।
3rd और 4th को आ रही है ना, खजुराहो।
हाँ हाँ,
हाँ। मदन
वो सर ने क्या
आ रहे हो कि
बनाने
नहीं?
को दिया है ना आपको।
मार्च, मार्च ना?
नहीं भाई, 3, 4, 3rd एंड 4th तो
खजुराहो, खजुराहो।
अप्रैल अप्रैल अप्रैल।
अप्रैल। हाँ,
हम्म।
प्रेरणा बोली थी बीच में, मुझे भूल ही गया बाद
सबसे
में।
इम्पोर्टेंट कॉन्फ्रेंस रहती है वो, सबसे इम्पोर्टेंट।
ओके।
आप आ जाओ मदन उसमें।
सही में आ जाओ।
अप्रैल में देखना पड़ेगा।
लेकिन मालूम है
उसमें
क्या
ही
वो,
करना है ना भाई, ये कल्चरल प्रोग्राम
कल्चरल
लगाना है ना
करना है।
उसमें।
अंताक्षरी मैं बना रहा हूँ पूरी ऑनलाइन, ये ऑडियो विजुअल,
हम्म।
बहुत कुछ करेंगे।
विद फैमिली रहता है क्या, सब लोग फैमिली आते हैं?
यूजुअली,
फैमिली।
मोस्टली।
ओके।
मैं तो
डिपेंड
फुल
करता।
फैमिली जा रही हूँ।
हाँ, हम भी।
अरे खजुराहो तो मुझे देखना था एक्चुअली, वहाँ के स्कल्पचर्स वगैरह, वो जो
मैं,
टेम्पल है।
प्रशांत, उन्नति, देवांश सब आ रहे हैं।
राइट, हम भी। कुछ तो विश
उसका
करेंगे।
ब्रोशर मुझे एक बार फॉरवर्ड कर देना।
अरे ब्रोशर वोशर कुछ नहीं है उसका, बस वो है ये।
पैसे देने, बस पैसे देने।
अरे कुछ तो
नहीं, ये
लगेगा
देखो
ना।
ब्रोशर में
आपने कितने दिए भाई, कितने पैसे दिए?
कुछ नहीं, वो लड़के ने मेरे को बोला कुछ, मैंने ऑनलाइन डायरेक्ट ट्रांसफर किया एक बंदे, 70,000 शायद, 70,000 प्लस।
मैंने भी
चित्रा
दिया।
मैम,
हाय,
Sir,
हेलो
गुड इवनिंग।
चित्रा मैम,
hello,
हाउ आर यू?
hello, hello, sir. I'm fine. So how are you, sir?
फाइन, एब्सोल्युटली फाइन।
Yeah.
हेलो।
So what Prerna is
क्या
going
कर
on
रहे हो?
munching something.
हाँ।
आई एम हैविंग अ कप ऑफ टी।
So
हाउ आर यू
it's
मैम?
nice. Yeah, I'm fine. Thank you, sir. These things.
सो
Very
नाइस टू
nice.
सी यू अगेन चित्रा, कांग्रेचुलेशंस, पार्टी ड्यू हाँ।
Yeah, you should give party. You're
फॉर
going to
व्हाट,
become
फॉर
a
व्हाट?
youth
यू बिकम
talent
पॉन्डिचेरी
committee.
सेक्रेटरी।
वाओ,
So,
ग्रेट।
yeah, sir. Just tomorrow, next week, we are taking over.
वाओ, ग्रेट। एंड हु इज
That's right.
प्रेसिडेंट?
ओके, गुड।
So Pondicherry, sir.
नो 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 नो, हु इज गोइंग टू बी प्रेसिडेंट ऑफ योर सोसाइटी?
Dr. Satyanarayana, sir. He's a specialist, a
ओके,
senior specialist, Rajiv Gandhi Hospital. So
ओके।
he's taking over. I'm
मैडम
from
नमस्ते,
Jipmer, sir.
अमला मैडम नमस्ते।
मैडम
सर
प्रणाम।
नमस्ते सर, नमस्ते।
हाउ आर
गुड
यू?
इवनिंग अमला मैम, गुड इवनिंग।
गुड इवनिंग सर।
यस,
गुड
डॉक्टर
इवनिंग
मदन
सर।
हियर।
गुड इवनिंग सर। गुड इवनिंग।
मैम को कॉल कर लेती हूँ ना, नंदिता मैम को।
नहीं नहीं, नंदिया मैम विल ज्वाइन लेट, कॉल हो
बोली,
गया हमारा। हाँ, शी इज
हो
बिजी
गया।
इन मीटिंग।
ये प्रेरणा
ओके,
का
आपका
ये
बात
सब
हो
कुछ
गया ना?
नहीं।
हाँ, बात हो गई अभी।
व्हेन आर यू गोइंग टू गया?
गया मैं कल जा रही हूँ भाई,
ओके, ओके,
कल की सुबह की फ्लाइट है।
ओके, ओके। नॉट, मेरे लिए पॉसिबल नहीं था।
आते तो अच्छा लगता है, यहाँ का कल्चरल संभाल दिया है मैंने।
नहीं देखा, मैंने देखा कुछ चाहिए होगा बताओ, इनपुट्स। अब नाउ यू आर मास्टर हो ऑन स्टेज। अभी बोलना नहीं पड़ता प्रेरणा को, अब तो प्रेरणा को खींच खींच के नीचे लाना पड़ता। बट मुंबई में
Prerna did
खास।
a very nice drama in that, what is that, in ASU.
राइट
Acha
राइट।
tha.
अरे शी इज वर्सेटाइल पर्सन।
Yeah, yeah.
या, She conducts
That's
the program very nicely. She's a very good actor in the dramas or mock kind of that kind
yeah, that was very
of
good,
on
very
stage and all.
impressive.
She's superb speaker. She's very fighting person in the debates. She will never lose any debate, huh?
Prerna, your treat for now. Treat from you
Okay.
for all this good things.
पति से कितना झगड़ा करती हूँ भाई यही बता रहे हैं.
अरे नहीं. Only she. I mean, I can challenge her only in impromptu. This is talk for 3 or 5 minutes. This time हम लोगों का डिबेट ये होगा कंपटीशन. प्रेरणा.
जरूर.
Prerna, sir, I have to go by 6:30, sir. Don't mind. We have a meeting with the director.
Definitely.
Is it too? Okay.
Yes, you can start your talk right on time and you can finish by 6:30.
Yeah. Okay, fine.
You are meeting the PM, no? Prime Minister आ रहे हैं ना.
He is meeting us. We are not meeting him.
एक फोटो खींच के हम लोगों को भी
Prime
भेज दो.
Minister.
No chance. I don't want to go near him. We don't know what's going to happen. I don't want to go near him.
No, you should.
You are
He is
meeting
coming for
Prime
the
Minister?
election sake to Pondicherry.
हाँ,
for that,
PM आ रहे हैं
yeah.
उनके जितमर में.
Oh my goodness, this is a lifetime moment then for you.
No, sir. Sir, it is so stressful, sir. Any VVIP visiting our area is so stressful.
Agreed, I do agree. But see, in spite of so much of eagerness, we people cannot get such kind of opportunities.
No, not like that, sir. So we won't be allowed to meet him. He'll come there. They have security when he enters. No, sir. No one should be in the corridor. No one. Only he and his security will walk in the corridor.
Exactly,
And
exactly.
and he goes on the dais. I mean, he comes out of dais, from dais to the car. No one should be there, sir.
Right.
No photo, nothing.
okay,
It's
good.
and when he gets on the car, no one should be in the surroundings. Only the even none of the staff member, no from JIPM. Only security sir should be there.
Okay.
So it's like,
proximity pass ना, proximity
हाँ.
pass जिनके पास है वो.
yeah, that all
Madam,
things
good evening,
will be-
Lata madam.
Good evening, good evening.
Lata
What
madam is
exactly
also
you are
munching.
And
Everyone is munching. Even Prerna was munching. Madam is also
I
munching.
have stopped munching. अभी नहीं खा
I've
रही.
just come out of OT, thanks to your case.
Ma'am. Thank you. She really took
I'm
our
just
case and did
seeing,
that.
eating only this thing, karbuja.
Musk.
Fruit. One muskmelon.
Yes.
Watermelon.
Watermelon.
Yes.
You
Good
didn't have
evening,
lunch,
Lata ma'am.
madam?
Good evening.
Where lunch, Chitra? By the time I finished, it was 4:15. Well, with that patient was very difficult. I made
Start,
assisted your
no?
PG now.
We can go live, Dr. Madan.
Yeah.
6 o'clock.
नहीं गेस्ट ऑफ ऑनर से भी ज्वाइन नहीं हुए ना.
At least guest of honor should be there, no?
मैम तो बोली थी टाइम पे आ जाएगी शर्मिला मैम.
I thought I was late.
It is
एक
exactly.
बार
शर्मिला मैम ने बोला था शी विल कम ऑन टाइम. विद्या मैम ने भी बोला था, संपत मैम ने भी बोला था, अमीर सर ने भी बोला था.
ये अमेश्वर का भी कॉल हुआ. ही ज्वाइनिंग.
हाँ.
Amay must be busy in Amogs, arrangements of Amogs.
एमोक्स भाई, अब मैं एमोक्स 13 तारीख को आ रही हूँ.
हाँ ना? मैं भी हूँ 13 को.
Tanvi?
यस विद्या मैम भी आ गए.
गुड इवनिंग विद्या मैम.
गुड इवनिंग विद्या मैम.
Good evening, Dr. Reena and
यस मैम.
Hello, Vidya ma'am.
yes, hello.
Good evening.
How are you, Dr. Madan?
Hi, Vidya.
Yes. How are you, ma'am?
Hi.
Looking so fresh.
Always.
Uh,
Vidya is always fresh.
Lata, how about you? Are you feeling tired for all the work you've done from morning?
OT. Konjam tiring after OT.
Nice.
Good evening, Vidya. Good evening.
Yes.
Good evening, ma'am.
Miss Charmila ma'am, welcome. Good evening.
Hey,
Good
ma'am.
evening. Hello, Charmila ma'am.
So
Hi.
nice
Hi,
to
Hi.
Hi.
Hi, Charmila ma'am.
Hi, Charmila ma'am. Good evening.
Good evening.
Yes.
Looking so fresh.
very vibrant in that
I'm
pink color.
exhausted.
Hi, Amaya. Hi,
Sampat ma'am, good evening. Amesh sir, good
Sampat
evening.
madam. Hi, Amaya.
And good evening.
Yes, welcome all.
Hi, ma'am. Hi, Sampath, ma'am.
I think we can
Good
start
evening,
now.
Amir sir.
Vidya.
Good evening. Good
Good
evening.
evening.
We can
Good
start.
evening, everyone. Dr. Charmila and Dr. Sampath Kumari. Good
Hi,
evening.
Lata.
Good
Hi.
evening,
Good
Lata.
evening, Sampath ma'am.
Long time.
Good
No
evening,
see.
good
Yeah,
evening,
long time.
Vidya.
Mama, good evening.
Amaya, good evening.
Hi, Amaya.
Shall we start?
Yes, yes, please.
Yes.
Yes, Darshan, please start.
Yes, sir. Good evening, sir.
Yeah.
So, on behalf of Corona Remedies, I, Darshan Waghela, welcome all the esteemed faculty members for this AMOGS Sexual Medicine Committee organized webinar in association with Tamil Nadu Obs and Gynae Societies. So, welcome all of you for this Core Connect live webinar. Moving forward, I would like to introduce Dr. Madan Kamble, sir. Sir is Chairperson, AMOGS Sexual Medicine Committee and National Coordinator for Foxy Sexual Health and STI Committee. I would like to hand over the session to Madan Kamble, sir. Sir, over to you.
Yes, thank you, Darshan. Yes, my co-convener, Dr. Prerna Keshan. She is the National Coordinator for YTP Committee Foxy. I welcome her. Yes, next. On behalf of Amogs Sexual Medicine Committee, with the blessings of President Dr. Kiran Kurtkoti sir and Secretary Dr. Bipin Pandit sir, I welcome all the dignitaries for today's particular webinar, which is associated with Tamil Nadu Obs and Gynae Societies. I'm very much thankful and delighted to connect with the Tamil Nadu societies, and they all have accepted our invitation. Thankful to all the societies. We welcome our today's chief guest, Dr. Nandita Palsetkar ma'am, and today's guest of honors, respected Dr. Amay Purandare sir, President-elect Amogs, Dr. Charmila Ayyav ma'am, past Vice President Foxy, Dr. Vidya Prabhakar ma'am, with the President of TNFOG, and Professor S. Sampath Kumari ma'am, with the Secretary TNFOG. I welcome all the guest of honors and today's speakers, Dr. Chitra ma'am, Dr. Girish sir, and all the chairpersons, Lata ma'am, Chandrakala ma'am, experts, Dr. Umayal ma'am, Dr. Sundar sir, and all the esteemed panelists for today's session. Amog Sexual Medicine Committee is always conducting these programs to create and spread the awareness about the sexual health amongst all the our gynecologists so that the society can benefit our knowledge in the sexual health, and we should deal with the sexual health issues in the adolescents and the adults too. So I welcome all the dignitaries to join the lamp lightning. Darshan, lamp lightning. Yes, thank you so much. Darshan, can I have CV of Nandita ma'am? Yes, we have got the eminent chief guest, Dr. Nandita ma'am. Everyone knows ma'am. Ma'am is the past president of Foxy, ISAR, IIG, MOGS, MSR, and she is working in FIGO also at many committees and projects also. Recently, she has got the Lifetime Achievement Award at ISAR, Ahmedabad, and we would like to congratulate ma'am for this. I welcome Dr. Nandita ma'am. Ma'am is busy in some meeting. She will join after some time.
Hi, Madan. Thank you so much.
Ma'am, welcome ma'am. Sorry, I didn't say. Yeah, thank you ma'am.
Yeah, I think I joined just in time.
Yes, ma'am.
I don't know who's talking. Okay. Okay. Thank you very much, Madan. Congratulations. First of all, I think it's a fantastic, you've taken up a mission making sexual health really important. And we all realize how important it is in the young adolescents and, of course, even in the older age group. So I really want to congratulate you because you've really taken it on as a mission and your vision is really pushing it forward. So, and with the help of Amogs, I think it is amazing. And I can see all my friends here. I don't know. I think Kiran, is Kiran here?
No, Amay sir is there.
Dr. Amay Purandre, yeah, we are looking forward to him taking over as the, Amogs president. Then there's Dr. Bipin Pandit, who is the secretary. And Amay, I'm really happy to be sharing the dais with you as you're the guest of honor and very proud of you. I think, and Girish, I could see Girish over here. I think Girish has also been all of you, I look at you all so fondly and so proud I am of all of you. Of the way you all have progressed, the way you all have gone ahead, and you all have become leaders. But remember that when you reach that leadership level, you have to create leaders behind you. And that is very, very important, that you need to leave a legacy behind. And that is very, very important. So I think I want to just wish you all the best. And Madan, all the best for your Foxy career. I am sure with your hard work and with a lot of efforts, you are going to be supported by everybody. I definitely do support you, and looking forward to you working in Foxy. I think our organizations are really beautiful. Amogs is the one which actually gave me a platform for Foxy. I think that's something very close to my heart. And I look at all of you all very fondly. You all have all homegrown Amogs people who have now done very well. Girish will become the vice president. Amma is already the joint treasurer of Foxy. So I think that's great. And you're all Foxy president material. So don't fall short of it and work very hard, and all the best. And congratulations for this wonderful seminar. Thank you. Thank you.
Thank you so much, ma'am, for being with us today. And you are the person due to whom I am here in Foxy. Thank you so much for everything. Thank you so much, ma'am. Yeah. I welcome today's guest of honors, Dr. Amay Purandre, sir, who is the Senior Vice President in Amogs and President-elect now. He was the Joint Secretary Foxy, and also he has chaired Foxy Committee also. And we look forward to his fantastic tenure as the President Amogs, who is taking over in March. We welcome you, sir, and over to you, sir, for your blessings.
Thank you, Madan. Thank you, Nandita ma'am, for those kind words of blessing. To all my friends from Tamil Nadu, Vanakkam, and to both the senior Amma and the Chinnamma, that is Sampat Kumari and Charmila, my respects. Most importantly, as we say in Maharashtra, Suswagatam, all of you are most welcome in Maharashtra. And I see this bond that we have between the Amogs, that is the Maharashtra societies, and the Tamil Nadu societies increase, both not just in numbers, more importantly in the work and the collaborations that we will do. Madan, I think you have taken the Sexual Medicine Committee to national heights, and I'm extremely proud of you for the hard work and the persistent efforts that you have taken. So congratulations on your successful tenure. I wish you all the best for your Foxy endeavor, and we are not going to let you go from Amogs. So you are an essential part of the team. You will be my state coordinator to coordinate the efforts. Dr. Bhaskar Pal has made you the CME coordinator, and like I said, the Mahab Gadbandhan is on. Every Foxy CME in Maharashtra will be an Amogs Foxy CME. So you have to keep working and spread the message and the good work across the state of Maharashtra and beyond that. Prerna, I see you as a very young and dynamic member of the Foxy, and I hope and wish you the best of luck in Nandita said, sincerity should always be there, loyalty should always be there, and hard work, no matter what comes before you, should continue, and success will be yours. What can I say about Girish? Um, you all will very soon see it in the Amogs conference. I'm keeping it as a suspense. Uh, Girish is going to make a big dhamaka in the Amogs conference, and note my words for that. But Girish, thank you for all that you have done for me. The family really considers you as a part of the family, and it's really a privilege to have you as a friend, as a advisor, and truly a true Amoxian. Wish you all the best, Girish, for your endeavors and your whenever you decide to take the plunge for the Foxy Vice President. The whole of India will be with you. To Sampath Kumari ma'am, okay, um, we want to see the Kanjivaram sari all over India. Okay,
Thank you,
so
Ameya.
so you have always been an extremely hard worker, somebody passionate about adolescent health, and I hope that you are able to carry that mission even to national and beyond national levels. Coming to the seminar, as usual, Madan has curated an excellent, very pertinent, and very informative and knowledgeable agenda today. And I'm sure with the uh, eminent experts, we will benefit immensely on this very sensitive, scientific, but extremely socially important topic. So, looking forward, and I hope the delegates will enjoy and get informed about all these important aspects. Last but not the least, I welcome all of you on behalf of the organizing committee of Amogs 2026 to Mumbai. Uh, Mumbai is Maharashtra's capital, but more so, it is my hometown, and I welcome you with open hands and an open heart to come and join in my installation and in the celebration of Amox 2026. Thank you once again.
Thank you so much, sir.
Madan,
Yes,
sorry,
ma'am.
thank you, Amay, but I really didn't realize that it's with Tamil Nadu. Sampath, I could not see you in the screen.
Yes, madam, I am there.
But Sampath, Kumari, I think is also, thank you, Amay, for saying all the things. But I think what we need to make an understanding is that we always support each other, that we are there with each other, and we need alignment so that we can all go ahead peacefully. And I think that's something we've done in the West Zone, and I think we should all work together so that that alignment continues and goes ahead. So yes, Sampath Kumari, all the
Thank you,
best.
Nandita
I
ma'am.
think that's
Thank you, Nandita
really,
ma'am, madam.
yeah, and even Charmila, I think, was there. So all the best. Sorry,
Good evening,
Severe
madam.
cold,
Madan,
I
please
think.
go ahead and thank Amay Purandre, please. Thank you.
Madam,
Yes.
for
Thank you,
what?
Nandita ma'am.
Yes, thank you so
You
much,
don't
Amay
have
sir.
you don't have to thank me, madam.
Yes, we are ready to take any responsibility given in Amox and Foxy. We will be very happy. Thank you so much. Over to Prerna to welcome the guest of honors.
Thank you. Thank you, esteemed faculties and everyone, our very beloved Nandita Madam and our guest of honors. And it's such a pleasant evening today, and I wholeheartedly welcome you all. And I'll have to invite our next guest of honor, past Vice President Foxy, Dr. Charmila Ayu, ma'am. So, string of stalwarts that we have with us today, pathfinders of many of us gynecologists, and the past Vice President of Foxy, Dr. Charmila. Dr. Charmila, ma'am, the dais is all yours for the blessings.
Thank you so much, Prerna. Respected Dr. Kiran Kurtakoti, sir, Dr. Bipin Pandit, Nandita ma'am, Dr. Amaya, and the TNFOG President, Dr. Vidya, and the Secretary, Dr. Sambat Kumari ma'am, and the conveners, Dr. Madan, as well as Dr. Prerna. It's a great honor to be in a webinar where the speakers are Dr. Girish, Dr. Madan, and of course, my dear Chitra, as well as Dr. Prerna. The chairpersons, Dr. Amla Devi, Dr. Rekha Rajesh, Dr. Lata, Dr. Chandrakala, Dr. Mayal, Dr. Sundar Narayanan, and the panelists from various societies of
Tamil Nadu. It's an honor to be in this program, and we've always wondered like how a sexual medicine committee can grow as a committee, but we have seen Dr. Neeraj Jadhav take a lead in that, and then Dr. Apurba is also doing great work. It's also very great to see Madan going in the same steps and doing the great work which has already been done by the previous committee chairpersons. It's usually an ignored committee, but the way the things are going, I think you're one of the best committees who have given the best work in a very, very limited resource setting, because you don't get the resources which any other committee can get. So it's very great. It's great to see you work in a committee like this, and it's always a pleasure to see Prerna as a person who's working forward. And Prerna is a beloved friend, I think, and almost like a sister to many of us. So Prerna, I would like to wish you the best, and I hope that we see you as a chairperson. And I'd also like to wish Dr. Madan Kamble for his future endeavors. All the best to both of you. Thank you so much for the opportunity.
Thank you so much, ma'am. And it's always a pleasure to hear you speak. And it's just a treat to the ears. Thank you for being here. And we are so very honored to have you amongst us. We have our next guest of honor, Dr. Vidya Prabhakar, madam. She's the president of TN Fog. And about Tamil Nadu, what we can say is that they're so inclusive and so warm people around. One phone call, and that was a big yes. So that is something that we are so very, very gratifying. But it's like something that we are really, really heartwarming gratitude we need to offer to the Tamil Nadu societies. Dr. Vidya Prabhakar, ma'am, for your blessings to us.
Yeah, thank you very much, Dr. Prerna. Both Dr. Madan Kamli and Dr. Prerna, I think both of you are extremely dynamic people working up your way in the Foxy, and I wish you all the very best. And actually, it is a big honor to be part of this program where we are sharing the dais with the ever cheerful and young-looking past president, Dr. Nandita Palshetkar, and all the other future presidents. Looks like the whole lineup is a lineup of future presidents of Foxy. So I would like to say good evening, very good evening to Dr. Maya Purandare, sir, and Dr. Kiran Kutkoti, and Dr. Charmila, who is always forever charming. Dr. Charmila, I see her in all the platforms wherever I go, whether it is a meeting or whether it is social media, everywhere I find her projected with her beautiful smile. And Dr. Sampath Kumari, ma'am, she is, of course, our very own TNFOG founder secretary. And in fact, it is her hard work which has brought up the TNFOG to the extent that is coming. And I wish her all the very best for her upcoming elections. And so all the other seniors like Dr. Amala Devi and Dr. Chandra Panasamy ma'am and all the other seniors who are there who are going to give lectures, and I'm eagerly waiting to hear about all that. I would like to say I'm very eager to listen to all this. Because the topics are very, very contemporary, and I feel that the social media on adolescent health and sexuality is an extremely important thing for all of us to understand. Okay, we all know that there are sexual problems in adolescence, but the effect of social media is something I think we all need to understand. And also the less focused, the less understood psychosexual crisis in the midlife as well. So very well curated topics. Thank you very much for having me here, and all the very best for this webinar. Thank you.
Thank you. Thank you, Vidya ma'am, for your words of wisdom. It's always a treat to hear you speak.
Yes.
We are so very honored to have you amongst us. Our next guest of honor is none other than Dr. S. Sampath Kumari, ma'am. Ma'am is the secretary of TN Fog, and more than that, ma'am, we wish that, like Amia sir has said, that the entire India should be painted with Kanjivaram. Ma'am, the dais is all yours for your blessings.
Thank you, Dr. Prerna. So the respected Dr. Kiran Kutte sir, Vipin Pandit, and the incoming Amogs president, Dr. Amaya Purandare. It was really nice to have the Amogs and the TNFOG doing the program together. And as everyone told, that always cheerful, our chief guest, Dr. Nandita. It is really an honor to share with Dr. Nandita and the coach guest of honors being Dr. Amaye, Dr. Charmila, Dr. our own president, Dr. Vidya. And we have the adolescent. It is really very, very important topic. 23% of our population is adolescent. So wherever there is a adolescent, I think Dr. will be definitely there. So you have taken the wonderful topic of sexual health and the psychosocial. And I welcome the speakers, Dr. Chitra, Dr. Girish, and the panel moderator, and Dr. Lata chairing the session, our incoming Foxy TNFOG president, Dr. Amla. all of them are here, and we will have a wonderful take-home messages from all of them. And I wish the best for Dr. Prana and Dr. Madan Kamble. And as all of you told, thanks a lot. And I wish all of you all to vote for me as a candidate. I am contesting for President of Foxy. Thank you, Dr. Prana, Madan, and Dr. Amaye for giving me this opportunity. Thank you.
Thank you so much. Thank you so much, ma'am. And we wish from the deepest core of our heart the very best for your future endeavors. Thank you, ma'am. So with this, we come to the close of the inaugural ceremony, and we extend our heartfelt regards to the Amogs office bearers, Kiran Kurtakurti sir and Bipin Pandit sir, and our very beloved and revered chief guest, Dr. Nanita Palshetkar ma'am, the very, very young and always smiling ma'am, with so much of her blessings always to us, and an honor to have her always with us by our side. The guest of honor, Dr. Amir sir, Chamila ma'am, Vidya ma'am, and Dr. S. Sampat Kumari ma'am. We are so very honored to have you all amongst us. And with this, we move on to our scientific session. For the first session, we have none other than Dr. Chitra T, the newly elected Secretary of Pondicherry OBGYN Society, and the chairpersons for this session are Dr. Amala Devi Jevaved and Dr. Rekha Rajesh Madam. Dr. Amala Devi is the President of Dharmapur Society, and Dr. Rekha Rajesh is the President of Krishnagiri Society. We welcome Dr. Amala Devi and Rekha ma'am, and kindly introduce Dr. Chitra ma'am for her deliberation.
Dr. Prana, only one point. Dr. Amla Devi is the president-elect of TNFOG. In June, we have the conference.
Okay, ma'am. Okay.
Thank you.
Society, no?
She's from Dindigul.
Dindigul. And not Dharmapuri. I have already informed you, no?
Yes, ma'am.
Yes. So good evening to everybody, and it's a great pleasure and honor to be a part of this Amogs CME. This is Dr. Chitra's.
I'm the president of Dindigul Society.
Yeah,
ma'am.
I am from
Yes.
Dindigul, and Rekha is from Krishnagiri.
Yes, yes.
Yeah. You show me the CV of Dr. Chitra. Chitra Tyagaraj. So she's reproductive medicine and minimal access surgery, and certificate course in advanced research methodology and affiliation.
Ma'am, thank you, ma'am. Thank you, ma'am. We'll just go ahead with that.
Awards, at least one or two awards I will mention.
No need, ma'am.
Purnima,
Thank you so much.
Yes, Natkarni Award, and then Dr. Asha Rao Award, no?
Yes, ma'am.
Yes. Okay.
Thank you, ma'am. Can I share the slides, ma'am?
Areas of interest is reproductive medicine, laparoscopy, and then
Thank you, ma'am.
All the best, Chitra. Chitra is a very good friend of mine.
Thank you. Thank you, Rekha. Thank you. Yeah.
She is going to talk on heavy menstrual bleeding in adolescents, which is a very commonest problem we are noticing nowadays in younger adults, you know.
Yes, ma'am. Yes, ma'am. That's the reason I thanks even have to go through this once again to talk on this topic, which is most common cancer problem in reproductive age group. And nowadays, any patients puberty age group having, especially with bleeding disorder, they come to OPD. So it has shown that heavy menstrual bleeding is excessive menstrual bleeding, which is really going to interfere with the woman's physical, social, emotional, and quality of life. Either it can it can occur alone or in combination with other symptoms. So when we go, what is a heavy menstrual bleeding? Usually in the past is diagnosed like more than 8 ml, but it can be sometimes can be subjective. So nice definition tells that women of I think some disturbance is there. Women for whom menstrual blood loss is significant, that it can impact the quality of life, it can interfere with day-to-day activities. Or when you ask the history of a patient, telling that she's changing pads every 2 hours, use double protection, and has a frequent swelling of clothes, blood linings, and if she is having bleeding for more than 7 to 10 days, and she requires the multiple change of menstrual products over the night, all these features tells that patient can be having heavy menstrual bleeding. So what is the prevalence? In one of the study, it has shown that it is an important sentinel for underlying bleeding disorder. When they found that approximately any patient comes to bleeding adolescent, they found that 20% of these girls had heavy menstrual bleeding and 30% of these were hospitalized because of heavy menstrual bleeding. And when they found to etiology, almost 50% did not have any etiology. In the remaining 50%, they found that anovulatory causes were most common, that is 25%, followed by coagulation disorders 19%, and platelet disorders in 6.2%. Then it's shown that the structural causes are very rare. The most common is anovulation, followed by the bleeding disorders. Why are we worried of heavy menstrual bleeding adolescent? Because it has shown that majority of 20% have this prevalence. Because of heavy bleeding, the patient can have symptoms of anemia, which can cause fatigue, dizziness, reduced physical activity, and also can affect the quality of life. Then any patients, students, or they cannot go to attend the school, they have a school absenteeism, and they have a reduced participation in the activities. And sometimes what happens, it can have a psychosocial impact also, like they can have an embarrassment, so low self-esteem, so low self-confidence, and always will be stress of where they might soak the dress and can have an embarrassment. And if you don't treat them, it have a long-term risk that patient can have a chronic anemia. It may lead to more morbidity in the future, like patient can have infertility, endometrial hyperplasia, endometrial malignancies. So what are the causes? I've already told you majority of the patients these are anovulatory. According to the palm coin classification, the majority, that is non-structural causes. Ovulatory dysfunction forms the most common cause, followed by the other what you call bleeding disorders. Then the last comes the structural causes. When you come to the normal menstrual cycles, you have seen in normal menstrual cycle, even the ovulation occurs, the progesterone occurs, the withdrawal bleeding occurs. In anovulation, what happens? There is a failure to release the egg, which can occur, which might lead to irregular bleeding, and it shows that lack of function of corpus luteum, where the progesterone is not secreted. There will be more of hyperestrogenic, and that may leads to unpredictable heavy bleeding because of the unopposed estrogen. So other than this anovulation, other causes which may lead to ovulatory dysfunction are the thyroid disorders, the hyperprolactinemia, PCOS, obesity. The anovulatory is the most common, that is immaturity or hyperthermia pituitary ovarian axis. When you suspect these bleeding disorders, any patients tell that she's having heavy menstrual bleeding from the menarche, and she has repeated recurrent epistaxis or ecchymosis or excessive bruising or delayed wound healing and unexpected injuries, or if at all she tells there's a family history of bleeding disorder, yes, you can have high suspicion the patient can be having bleeding disorders. The most common can be von Willebrand disease, immune thrombocytopenia, followed by factors 8 and 9 correlation defects. Other causes, it can be very rare, but you need to remember that it can be pituitary ovarian deficiencies, it can be iatrogenic secondary radiation or chemotherapy, it can be due to secondary to medication, especially if she's taking any anticoagulant drug or contraceptive pills. It can be secondary to sexually transmitted infections, or it can be due to malignancy, where it can be estrogen secreting or androgen producing tumors, or as PAMCON classification. This is very important. When you take the history, you have to rule out each and every factor. So how you are going to evaluate this patient who come with heavy menstrual bleeding? As I've told you, history plays a very, very important role. In that history, it is a menstrual history. When you take the menstrual history, you should ask about the age of the menarche, the length of the cycle, the regular or irregular, the number of pads, is passage of clots, is of number of changing pads in the night, or what is the impact of this bleeding on the symptoms or other conditions, and any other associated factor like dysmenorrhea, dyspareunia, dysphagia, bowel symptoms, and any bleeding symptoms what I've already mentioned. Well, and you have to rule out any risk of underlying causes what I mentioned. Take a detailed drug history, family history, or any past medical history. And a sexual history in patients who are sexually active, you should need to know any risk of pregnancy there or sexual transmitted infection, whether the patient is using any contraceptions, all those things. And this all should be asked with taking an informed consent of the patient. And how these factors are impacted the quality of life. So it's very important to find out the social history, like whether the patient, woman, the girl is going to the school, what are any concerns of rebullying, self-confidence, effect of symptoms on her relationship. Once we know the evaluation of this thing history, next is examination. Usually gender physics examination is one which can be done, but not necessarily all patients should go under examination. Only in patients who are having an hypertension, tachycardia, which can lead to secondary causes might be done. So what are the things you are going to see in physical examination? Check for a height, weight, BMI, see for the arm span, check for the thyroid stagings, thyroid enlargement or a galacturia, see for the breast, what is the staging of the breast, look for any lymph nodes if you're suspecting any mass per abdomen or malignancy, look for the signs of anemia, PCOS, secondary negligence, hypertension symptoms like hirsutism, acne, or look for any bleeding disorder signs like petechiae, bruises, or any thyroid disorder like dry skin. So abdominally, you have to see for check for any distension or hepatosplenomegaly or any pelvic masses. And when you see the local or general examination, like local examination, see for the standing stages of the development of sexual organs. Speculum examination is not typically required. So very important clinical assessment is detect anemia, detect hyperandrogenism or any bleeding disorders. So the evidence tells that there should be a detailed history taking, including the medical and family history. Physical examination should be done is crucial in determining the likely diagnosis and urgency of immediate treatment. In that, the menstrual cycles is very, very vital. And if at all a patient has maintained a menstrual calendar, it is very invaluable too. Then coming to the investigation, once you do the examination, to assess the blood loss, first you have to do blood grouping and RH tapping in case if you need to do blood transfusion along with the complete blood count, peripheral smear and serum ferritin levels, and to rule out endocrine disorders like thyroid, PCOS or hyperandrogen conditions. You have to look for TSH and LH, FSH or AMH, testosterone, DHEAs, 17-alpha progesterone, prolactin. To screen coagulopathy disorder, you do the bleeding time, clotting time, PT, IPTT, INF, fibrinogen, and for von Willebrand panel and factor 8 deficiencies. And others, if the patient tells in the history that she is sexually active, yes, you have to rule out sexually transmitted infections, rule out any pregnancies. And if patient is severely anemic, yes, you have to do for blood grouping and RH typing. Imaging is rarely indicated until unless patient is not responding to medical management. And when you do the ultrasound, you should form the tiered approach. What is this tiered approach? The tiered approach is the one which will be used to evaluating the bleeding in adolescents. The first, any patient comes first, just if sexually active, rule out the pregnancy test, rule out pregnancy and do complete blood count, do the ferritin levels, PT, APTT, thrombin time and fibrinogen levels. The second titers includes the TSH, von Willebrand profile, total and free testosterone, DHEAs and testing for any sexually transmitted infection. The third tier, if the patient, if you don't get any information from the first and two tiers, then you go for the third tier where you do the platelet function and aggregation test. When you do the test, next comes the management. When you take the management, it should be morely hormonal and non-hormonal. In the hormonal, you have a combined or contraceptive pills or a progesterone only pills. And non-hormonal, you have a tranexamic acid and a mefenecamide. Other things is desmopressin. So what is your goal of management? First, you the classification of the pubertal anemia, whether it's mild, moderate, severe anemia. What is the underlying cause, either by the history or by the examination? And main important is the control of the bleeding and prevent the further episodes. That's a maintenance therapy. And you have to treat anemia concurrently. The things which can be so this is a tiered approach, and this is 4 tips for patient-centered. First, assess the hemodynamic stability, assess for the blood loss, control the active bleeding, and use the other things of consulting with the hematologist to rule out any bleeding disorders. So hormonal therapy, what are the options and efficacy? Any patients come with acute, the high dose of conjugate estrogen should be given first, 25 milligram IV if it is available. If not, combined oral contraceptive pills, the dosage of 30 to 50 microgram ethanol estrogen should be given. Or if the patient contraindication is there for COC, or if it's not available, medroxyprogesterone acetate should be given 20 milligram at least 3 times daily until bleeding get control, or non-ethadone acetate. If at all this is there, once this can also be initial management and followed by maintenance can be done by this, or maintenance can be done by the combined patches, vaginal ring or DMT injection or etonogestrone implant. So combined methods can be used only for cycle regulations or management of the menses. Progesterone only can be given only for few cycles, but long term you can give only COCs. Why do you give hormonal therapy? As we know, the exogenous estrogen permits additional endometrial proliferation. It heals the sites of any endometrial bleeding and provides hemostasis. And when we give progesterone, it stabilizes the endometrial lining. So in our India, we give first line, or most of the time we have a conjugated estrogen not be there. So we try to give the combined oral contraceptives. When you give a COCs, the monophysic, we should give the high dose, like 30 to 50 microgram of ethanol estrogen should be given. With the second generation, progesterone should be the first line of management. And in continuous or external cycle is always preferable. And when you're using the extended, either you can give in patches or ring also. It should be considered, especially in these patients who are having bleeding disorders. If at all any of these women having a excess breakthrough bleeding, either double the dose of what management she is taking, or try to, if it is taking 30 microgram, make it to 50 microgram of ethinyl estradiol. Progesterone is given for patients who are do not tolerate estrogen containing pills, or in whom estrogen is contraindicated. So it can be given either medroxyprogesterone, like what I told, 20 mg, or non-ethadone can be given 50 mg daily for menstrual suppression. Now, because of intramuscular medroxyprogesterone causes intramuscular hematoma, subcutaneous formulation can be used, and etonormazole, usually contraceptive, is not indicated in patients with adolescents, especially with the bleeding disorders. Even we are worried when acute IUCD can be used or not. Yes, IUCD can be used in these adolescents if there is a failed medical management, if the patient is having difficulty in adherence to daily, weekly, or monthly injections. And copper IUCD is usually not recommended because it's shown that it can exacerbate bleeding, and especially in patients with bleeding disorder. So the choice is the LNG IUCD. So it appears to be very effective therapy in a patient, especially with bleeding disorders. It is shown with minimal complications, high rates of adherence will be there, and it also shown there's an improvement of heavy menstrual bleeding and anemia. And it also has an added benefit of having effective contraceptive, especially if the adolescent is having a sexually active, and there's a higher continuation rate and higher satisfaction rate. So coming to the non-hormonal first line, which can be always given adjuvant along with this main hormonal therapy, especially in patients with bleeding disorders. Tranexamic acid can be given initially 1 gram per kg, 10 milligram per kg IV, or 25 milligram orally for every 6 to 8 hours until the bleeding stops. Then you can change it to oral tablets. Aminocapric acid 100 to 200 milligram per kg, maximum 30 grams per day, should be given every 4 to 6 hours. And desmopressin, which is on factor 8 release, it can be given at 0.3 microgram per kg IV or subcutaneously. Intranasally, 150 to 300 should be given. It can be given daily for a period of 3 to 5 days. Non-hormonal treatments, especially for the anemia. This, I think WHO has told that any children or girls more than 12 years, the hemoglobin should be more than at least 11 gram %, and the serum ferritin level should be more than 15. If at all any adolescent have a heavy menstrual bleeding, this shows that for every 1 number of blood loss, she is losing around 0.4 to 0 milligram of iron, and the incidence of this iron deficiency anemia in adolescents is 9%. Without anemia, the iron deficiency goes as 15%. So according to CDC and American Association of Pediatrics have recommended that annual screening for adolescents who are at risk of developing this iron deficiency should be screened, but they're not told which is one single diagnosis which can be done. And ASOG recommends at least try to do complete blood count and iron studies wherever feasible. So this is the treatment of different levels of bleeding in adolescent according to WHO. If the patient has a mild bleeding where the HP is more than 11 gram, you don't have to do anything. Reassure, give education patient about the consequences, the follow-up, and what should be taken. They can be given with low dose OCPs or iron supplements, or progesterone can be given. Check the progress after 3 months. Even if along with the hormonal contraception, you can give even antifibrinolytics or NSAIDs. If the hemoglobin is between 9 to 11, yes, you have to start education regarding the bleeding disorders, do for the testing for any STI infections or bleeding clotting problems, and give iron supplements, low dose OCPs along with progesterones, antifibrinolytics, and NSAIDs can be given. Follow up every 2 months. If the patient hemoglobin is very severe, 7 to 9, yes, again you have to counsel the patient, check for bleeding disorders, give iron supplementation, but here you have to start giving high dose OCPs along with antifibrinolytic, progesterone, and GnRH can also be done to down regulate. You have to reevaluate these patients after 1 month. Very severe, yes, you need to admit the patient, stabilize the patient, rule out any clotting problems, offer the blood transfusion if needed, and you have to give intravenous tranexamic acid, high dose control pills, along with, in extreme cases, if at all is not controlled, then you can go for hysteroscopy. If you find a clot, remove the clot, or you can do the curettage. All nowadays suggest that balloon tamponade and Mirena can also be used in these patients. We know every medical management carries some risk, and it can be mild to severe long-term. And OCPs, we already know, mild are nausea, vomiting, breakthrough bleeding. Serious, because of estrogen, you might have thromboembolism, and because of progesterone, long-term, you need to have a patient can have and decrease bone mineral density. So whenever we give the medical management like OCPs or progesterone, we very important to counsel the lady, counsel the girl on to the patients, parents also regarding the common side effects of high dose estrogen, vomiting, headache, depression, fluid retention, and you should see that these are not contraindicated or not given in patient with liver disease or history of thromboembolism or cardiovascular diseases. And even the progesterone side effects also should be explained to the patient. Combinedly, the patient can have acne, weight gain, and hoarseness of voice. The ACOH recommended this. Yes, in patient who are having low dose, there can be breakthrough bleeding, and they can have discontinuation in the management, discontinuation, the continuation of OCPs. Then in any woman, adolescents come with acute AUB. How do you manage this? Main important goal is control the bleeding and correct the anemia. When you control the bleeding, first I told you, if you don't have conjugate estrogen, you can give COCs and progesterone if estrogen is contraindicated. Concurrently, you have to give tranexamic case also. If you're giving conjugate estrogen, 25 milligram IV should be given and should be continued every 4 to 6 hours for 24 hours. COCs can be given high dose 30 to 50 microgram, and every 6 to 8 hours till the bleeding stops, then you can taper the dose. Medroxyprogesterone 20 milligram orally at least every 4 to 6 hours, taper once the bleeding controls. Non-ethidron 20 milligram orally every 8 hours till the bleeding stops, then maintenance dose can be given further. Anemia, yes, oral and iron supplementation is more than enough for this patient because they are able to sustain the blood loss unlike the adults, and blood transfusion is not necessary. And the recommendations tells that it should be given blood transfusion only in restricted patients, that patients who are hemodynamic unstable, who are having heavy bleeding, which is not responding to medical management, has a very severe symptoms like tachycardia, lethargy, syncope. Yes, you should give blood transfusion, and it should not be based on hemoglobin alone. It should be combined, because unless you give blood transfusion, it can lead to allogenic transfusions. So non-medical management, yes, I have, it is mainly by the either tamponade or evacuation. It is given in patients who lack response to medical therapy or who are critically unstable in spite of initial measures, or in whom severe bleeding warrants further investigation like examination anesthesia. It has shown that surgical options like intra-aortic balloon tamponade can be used using a pediatric catheter, putting 20 ml of normal saline, or section evacuation. If you find on ultrasound some clot is present or some intra-aortic mass is there, you can do the suction evacuation. Very in severe cases, you can do endometrial ablation, uterine embolization, or to save the life of patient, you can do hysterectomy, but it is not needed because of the present management, recent advances in management. But you have to explain, if you're going for this position, there can be morbidity in the future with the patient can have premature ovarian failure, can also lead to infertility. So it should be considered only in life-threatening situations. So once you control the initial bleeding, long-term management also is very important to prevent the long-term morbidity. So the same thing what you give, the hormonal, non-hormonal can be given. And main part of giving this maintenance therapy is it's a safety. It should have a bleeding cessation, menses regulation, anemia correction, and fertility preservation. So anemia should be corrected not until only till the anemia resource iron supplementation should be given. Very important for us to improve the hemoglobin and quality of the life, the maintenance therapy. So iron therapy, I have already told you, you can oral iron therapy. First line can be oral iron therapy. If the patient is not tolerating oral iron, you can go for the parental iron. Blood transfusion is not at all necessary in these adults. When you give the doses, see that it contains 60 to 120 milligram of element iron per day. Once a day or alternate day should be given instead of giving multiple doses at the same time, because it's shown that they release the hepcidin levels, which can decrease iron absorption. And duration therapy should be directed only because depending on the severity of the anemia and the response to the treatment. How you know the response? You do the ferritin level. That is, if ferritin level is more than 15, yes, the patient has responded, you can stop the iron therapy. Other gynecological consideration which you have to think when a patient with a bleeding disorder is a hemorrhagic Gorin cyst. Many times you might have opened up thinking it's a hemoperitum, and we see there is a rupture of the corpus luteal cyst. So in a one study, it is shown that 52% of the women with von Willebrand disease had this hemorrhagic cyst. And this is usually occurs of excessive bleeding into the corpus luteum at the time of ovulation, and this may lead to hemoperitum. And sometimes we might end up opening, but not necessary. We should never do laparotomy in this patient bleeding disorders having hemorrhagic cyst. You can put on systemic hormones or LNG ICD. Usually it resolves on its own. So whenever we find adolescent with underlying bleeding disorder, it's very important, like they have to be counseled along with their patient, along with their parents, and so that you know the possibility of the patient can have heavy menstrual bleeding, develop a plan if she has heavy menstrual bleeding, how she should respond to that, and whether we have to consult with the hematologist and make a plan for it, how the treatment can be given. The ACG recommends any patients, adolescent having a heavy menstrual bleeding disorder should have a first reported visit 13 to 15 years. But in patients who are having early menarche, have heavy menstrual bleeding, can come before 13 years. Yes, when you do the counseling, emphasis should be maintain the menstrual calendar on correction of the anemia. If at all patient is obese, optimizing the weight, and if at all a patient is on hormone therapy, you should tell about the side effects and any breakthrough bleeding and what should be done. And also important, the risk of this future morbidity, the endometrial hyperplasia or endometrial carcinoma. So gynecological concern these patients is like in adolescent with known bleeding disorders, sometimes patient can have a pre-operative surgical evacuation. There can be choice of hemostatic agents for control. Improper blood loss can be there. Can be need of multiple blood work should be given. So everything should be done in consultant with the hematologist and the anesthesiologist. And in an adolescent who are sexually active, there can be a vaginal trauma like sternal injury or coital injury. And this in these conditions, allow in addition to surgical management, hemostatic agents and factor replacement should always be done. So in conclusion, I like to tell that heavy menstrual bleeding, the most is often if mainly because of immaturity of hypothermia pituitary axis like annuality, followed by bleeding disorders, and structure causes are very rare. In all these patients, you have to do thorough clinical history and examination, very essential. And screening for bleeding disorders and immunization anemia should be included in initial evaluation of girls with heavy menstrual bleeding. The first line of management is always an hormonal. You should not only acute management, maintenance is also very important. Along with the main management, non-hormonal adjunct can be also be given. And transfusion, remember, it should be only restrictive. So the care of girls and adolescents with bleeding disorders should be in consultation always with the hematologist and ideally at the multidisciplinary clinics. So early intervention in this patient shapes the healthier futures. So this is a summary which I have already mentioned. If the patient, if at all PGs are joining, if the patient comes, yes, you have to initially evaluate it, do for the examinations, find out any breast skin examination, take off the history to know the patient really having heavy menstrual bleeding, do the set of investigation, especially in the clotting disorders or bleeding disorders. And if the bleeding is very severe, you have to admit the patient. If the bleeding is not severe, the patient can be managed on the OPD basis. And inpatient, yes, always you have to consult the hematologist and necessary do the ultrasound and start the hormone therapy. If estrogen is not contraindicated, yes, you can go estrogen therapy. If it's contraindicated, progesterone therapy can be done. If the bleeding is controlled, you can add antiphospholic. It's not controlled, increase the dosage of this hormone contraceptive pills. Always maintenance is very important. Along with the hormone therapy, iron supplement should also be given to prevent the anemia status, to improve the quality of life. Yeah, these are my resources, and thank you so much. Thank you for the opportunity.
Yes,
Thank
so much,
you,
Chitra.
Dr. Chitra. It was a wonderful presentation, but
Oh,
more faster than the Vande Bharat. Vande Bharat. It was more.
yes,
But
that
you
I
are
was
not
already.
adopting even a single word of
Now
this
Lata madam will tell something.
topic. Yeah, not even sentence, not even a single word of this topic. The heavy menstrual bleeding. Why we should give importance for this problem of young adolescents is that they will become the future mother. So in this age, the anemia should be not only treated, but it should be prevented. The prevention is in them will carry a good mother in the later part of her life. First thing, it should give her the history taking is very, very important. Every
Yes,
part
ma'am.
of it, you should ask how many. You almost narrated that. And the other thing is examination also, not of causes of this our immature system of the hypothalamo pituitary axis or any other thing which is the cause for this. That is usually the bleeding cause, bleeding diathesis or something, this idiopathic thrombocytopenia like that. So it's a very good presentation, and we should give awareness like we are giving awareness for cervical cancer or some other cancer. We should give awareness to all the school children and those who are in the adolescent group to how to report immediately or They should not, because last week I had one patient came with 3.3 grams of hemoglobin. When we went into the history, she was bleeding for more than 15 days. The most of our South Indian girls, maybe due to their financial this thing, or not having any awareness regarding this bleed. Some may say that it is common. It may be common, it may be treated, but in spite of that, it should be treated immediately. She should not lose even a single drop of blood from her, apart from her regular cycle. The excellent, and then Dr. I thank Dr. Pranav and the other organizers of Amogs for giving an opportunity for us, for the South Indian gynecologists and obstetricians, to be a part of this program. Thank you. Thank you so much.
Thank you, sir.
Thank you so much, ma'am. Thank you so much. Rekha, ma'am, do you want to have inputs?
Chitra, it was a good presentation. Yeah, but I think like how Amla madam told us, it's our responsibility to create an awareness and make these girls realize that, you know, they have to come and tell us when there is a problem. And they also have to realize there are a lot of inhibition, especially in the peripheral areas where we stay. And the awareness has to be rampant. And the presentation was quite good. Thank you.
Thank you, Rekha. Thank you, ma'am. Thank you, sir.
Thank you so much, Chitra, ma'am. It was really wonderful presentation. Thank you so much. Yeah. Thank you, chairpersons, for chairing the session. We will move on to second session. Darshan, can I have the CV of chairperson second session?
Yes,
Darshan?
yes, sir. Yes, sir. Just a minute.
Second session, we have got the eminent speaker, my elder brother, Dr. Girish Mane, sir. And the esteemed chairpersons for this session are Dr. Lata Chaturveda ma'am, who is the senior OBGYN and currently the president of Pondicherry Society, and Dr. Chandrakala M. ma'am, who is the president of Kovai Society. I welcome both the chairpersons, and I requesting Lata ma'am to introduce Dr. Girish Mane, sir.
So can we have his CV? Yeah. Very good evening and thank you Amogs and of course Tamil Nadu Society for giving me this opportunity. About adolescent health, I think, which is the need of the hour, and what Dr. Girish is going to talk is really, really important. I think everyone knows Dr. Girish Mane very well. He's been past president of Avatmal Society, so many to his credit. And I think recipient of Foxy Smriti Mailan Save Baby Girl Runner-Up Award, and so many to his credit. So before going further for his talk, I think the social media and the impact on adolescent health, I think it's the need of the hour. Many of our children, I mean girls, I think even us, we get addicted to social media, simple things like playing games and all. It's not just that, going to YouTube and, you know, watching something which is not necessary, or something like body shaming, and getting, you know, posting their photos and then getting bullying. All those things are something which may be a negative aspect of social media, but there are something positive also to it. Let's listen to Dr. Girish Mane, I think, who is expert in this subject. Over to you, Dr. Girish.
Thank you very much, ma'am. Lata ma'am, thanks a lot. And probably this is my old CV, and Dr. Madan has forgotten one of the bestest credential in my CV. That is, I was the best chairperson of Foxy also. So probably,
Okay, sorry.
yeah, it was very old. So thank you very much, dear Madan and Dr. Prerna, for this opportunity, and thanks a lot, Dr. Kiran, Dr. Bipin, and everyone from the Amogs. I'll share my slide first. Is it moving, ma'am?
Yeah, it is.
Okay. So before starting my talk, see, whenever we are having any adolescent program, might be it is we are listening something on heavy menstrual bleeding on in adolescent, or adnexal mass in adolescent, or psychosexual problems in adolescent. But social media is not a problem which is specifically for the adolescent. I think it is common for the adolescent as well as for the adults also. I mean, there are many things which correlate with each other. There are very small things which are different in the adults and the adolescents. So, just a moment. हे माझा हे दिसत नाही अरे मदन सर
Not moving.
नाही नाही
Any
माझं
problem?
हे दिसत नाही मला काय म्हणून
It
झालं
was moving earlier, but right now.
no no just a minute I did something wrong actually
Think. Please stop share and again reshare.
yes आता ओके
Yeah. हाँ दिसते.
is it moving now
Yes, yes.
okay. So at the outset, I would like to extend my sincere thanks to all the Amogs office bearer, the guest of honors, and today's speakers, moderators, all chairperson and experts. Thank you very much. So friends, these words, independence, slavery, thraldom, do you think that we are independent right now? I think we are not independent still today, and we are doing the slavery. Way years back we were doing slavery for the British people, then we were doing slavery for the English trade, we forgotten all our Indian traditions and all the things, and nowadays we are doing some kind of social slavery. This social slavery is nothing but it's a digital lifestyle which we have which we are adopting nowadays in our day-to-day life. Thank God, I always thank God that these all things, social media and all these things, they were not in my childhood as well as my adolescent age group. Otherwise what would have happened I don't know. So there are loss of thousands of the productive hours, not only in the students but in the people who are supposed to work in the offices, who are supposed to work in the industries, and many boys and girls, they are nowadays busy in making the reels instead of studies. They want to be YouTuber, and nowadays the comparisons are not in between what you are going to be in your future. Are you interested to be a doctor or engineer? But most of the people now, they are interested or they are comparing themselves as a YouTuber or the reel makers, and they want to be an influencer instead of becoming either district magistrate or engineer or a doctor. So this is a very bad scenario in day-to-day's life. So friends, social media is not a media, but it is just like a ghost which has covered almost every era. Not only the small, adolescent, but even the small kids. They are so obsessed with the social media. If a small boy or a girl, they are having some tab or some kind of mobile in their hands, and if you are trying to take it from them, then they will shout. Shout on you, the young boys, then the adults, the adolescent, and not only these people, but even the adults, everybody is obsessed with social media nowadays. We are spending 2, 3, 4 hours without any knowledge for this social media, and we are not even aware of that. So instead of going on for the gym, or instead of going on the ground for walking, or instead of doing giving time for your hobbies, everybody is obsessed, and we are wasting a lot of time on this social media. And in India especially, the social media users, they are increasing horribly. You can see on this chart how the boys and the girls, and I mean the all the Indians, they are getting engaged in this social media. If you see this chart in United States, a common person in the United States, they spend 2 hours and 25 minutes on a social media, but in India, one Indian is spending almost 3 hours and 7 minutes. And what I know, in USA, these guys, I mean the boys, girls, or all other people, they are even using the social media for their studies, for their businesses, for their trades and everything. But what the Indian people, they are doing on the social media by spending 3 hours and 7 minutes, it's a very big question. Correct. So what exactly the social media is? There are many various definitions of social media. For example, the social media refers to the website or the application which connects the people, which shares the information, ideas, personal messages, etc. So there are many kinds of the social media, social network, giving lots of information and all. But in my view, I will like to define the social media that social media is something which connects you or everyone with everyone at the cost of your own people. I mean, you are connected with your friends in other state, you are getting connected with your friends in other countries also, but you are not having a simple knowledge about your own people, what your mama is suffering from, what your daddy is suffering from, what your sister has achieved, what your relatives they are doing. You will never get an idea, and that is what the social media is exactly. Where is today's youth? Today's youth is together, but they are not together at all. They are busy in their mobile phone checking the notifications. They are very busy in doing the chats with the people who are far away, and they are not taking care of the person who is next to them. They are literally engaged in so many activities simultaneously, not only in the studies but even the affairs which are doing out of the home. Nowadays it is said that lucky are those who have plug point near their bed to charge their phones, isn't it? And this is what the Mother's Day, a single day out of 365 days, everybody is clicking the photo of the mother, and these are the others days when the mother is absolutely alone. Everybody is busy with their phone, with the social media, and with their own work. So there was something in Hindi which is, one phrase that neki kar or dariya mein dal means do something and just forget it or throw it in a sea and nobody should know it. But nowadays the definition or the proverb has been changed and it is neki kar and Facebook pe dal. Means even if you are doing a silly thing, you will click it in a very fancy way and everybody is very interested to post on the Facebook and making something very different or very silly or very full presentation of your own. देयर वॉज वन डे, इट इज़ इन हिंदी, इट इज सेड दैट एक समय था जब मोबाइल गिर जाता तो बैटरी बाहर आती थी. मीन्स देयर वॉज वन डे व्हेन माय मोबाइल यूज टू फेल डाउन, द बैटरी यूज टू कम आउट. But nowadays, whenever my mobile fell down, my heart comes out. This kind of message is given in this. Yeah? My reaction after seeing the plug point when my battery is about to die, and when a boyfriend and a girlfriend, they are sitting in front of each other, they are not very much comfortable to talk with each other because now they are addicted to talk on the phone only. And that's why this boy is saying that pick up my phone, I want to talk something romantic with you on the phone. And if Mona Lisa would be in today's era, this would have been her pose, that is pouting of Mona Lisa in front of the phone. So friends, social media is nowadays not at all used as a medium for the communication in between these boys and girls, and it is not more lesser than a slow poison. It is harming their health, it is harming their social connection with the people, it is harming their studies, it is harming their future, and that by that way it is harming literally the future of our country also. These are the facts of social media. Most of the people, they don't know that one adolescent clicks the phone averagely for more than 2617 days in a day. Then if any adolescent, he or she, they are using a smartphone or tab or laptop just for entertainment for more than 5 hours a day, then the average suicidal rate amongst these kind of boys and girls, it is more than 71%. Then they are getting their sleep lesser than 6 hours, and most of the boys, they are feeling the depression, and it is more than 47 and not 27, it is by mistake. Then 60% of the adolescents, they check their phone even if they are not getting any kind of notification or ring during the classes, during the jobs, or during the work. And in 80% of the adolescent, their sleeping partner is a smartphone and not anybody else's. And more than 30% adolescent, they feel their life literally miserable if they are without smartphone. And unfortunately, 7 out of the 10 parents, they are not worried about these problems with their kids, because all these parents, they themselves doing all these things what their adolescent boys and girls, they are doing. There are multiple bad things about the overuse of the smartphone. For example, the smartphone definitely will hamper the brain development of the kids or the children, which majorly happens in the childhood with the fastest mental development. And nowadays in many homes, the you can say the smartphones, they are the babysitters. The mothers, they have to use the smartphone to make their children sleep, or to make their children to have bath, or to make their children to have the food also. Then this can have permanent bad impact on the familial relation of the child, and that child will start liking the smartphone and not the mummy or masi or bua or father or any other person. Then it disturbs the sleep, and that's why it will definitely harm the complete day, because the boy or girl who is sleeping very late in the night will definitely get very problems in getting up in the morning. Then they will attend the school with pressure. Definitely they won't have any attention in the school, and that's why the whole vicious cycle will go on. Then it disturbances in the lifestyle, endures the academic ability, and that's why the future of the kid. Then every knowledge is available on a single click, and that's why the diversion of these boys and girls is very easy if they are using the smartphones. the probability of getting involved in the pornography or the games or the cyber crimes and many other things, it's very easy for the boys and girls who are using the smartphones. Then skill development is almost zero, because there was one day when I used to remember more than 25 phone numbers of my relatives, my friends and everybody. I used to calculate maximum mathematics on my fingers. I used to remember the birth dates, I used to remember the anniversaries, but now, unfortunately, not only me, but most of the people, they are forgetting everything, and that's why our skills, they are getting literally out of the skill. Then there are bad impact on the interpersonal relationship, because now I am not interested to go for the marriages or for the birthday parties, or even to go, I'm not interested to go in the summer vacation to my mama, because I'm meeting all these guys on video phone and I don't have any curiosity about them or their home and any other things, correct? Then skillful one-to-one communication is literally affected, because now I am using only emoji. I cannot make smile on my face. I'll send up emojis to the other people. I cannot show anger. I cannot show anxiety on my face, because everything I am using only with my fingers. Then the boys and girls, they are losing the physical activities, and that's why bad food habits and unplanned economical expenditures, because I have to just click one single button, I have to pay, and that's why I'm not getting literally how much I'm spending out of the packet of my mother and my father. Then that's why the obesity, various diseases, family issues, psychological issues, depression, suicidal tendencies, and whatnot, these boys and girls, they are getting. And the most important thing, using the smartphone in the bathroom or washroom is carrying a lot of infection in the kitchen or in the dining table, and that's why many diseases, they are getting spreaded, correct? So this is the statistics of youth usage in India, and unfortunately it is very huge. It is literally, I mean, on a very bad verge, and there are some factors which contribute to this issue. For example, the nuclear family, the boys and the girls who are in the nuclear families, because they don't have any other person to share their ideas, they don't have the person to share their time, or they don't have any other person to talk upon, and that's why the smartphone is their best friend and best relative also. Then if the parents are working, the mom is going out, the father is going out, then the chances of this adolescent getting engaged in such kind of activities is more. Then no special time for kids. The people who are very busy in doing the medical practice, the mothers who are busy in delivering the children of others, they are losing their own children because they are busy. They don't have time, special time for their kids. Then the parents who are using the smartphones or social media in front of the kids, they are giving, they are pushing their kids towards the social media. Then if there is no parental check on the use of social media by the kids, then the chances are very high. Then overburdened studies and competition is one of the reason, because see, after doing a study or after doing the comparisons with the boys and the girls who are getting very high marks, then just to relieve the tension, once the boy or a girl, if they take some mobile in their hands and if they scroll for only one reel, they will definitely watch more than 50 or 100 reels unknowingly. This is one of the reasons. And the most important is ignorance of the culture is one of the reasons. And I'm very happy that my son, he is studying in Hyderabad, and nowadays what I find that the culture in the south of South India or southern part of the India is quite maintained as compared to the north. And if you go more in the north, then you will find that the culture is really literally, I mean, hatched in the northern areas. There are these are the social media affects the, why the social media affects the adolescent brain differently than the adult brain. For example, if an adult and a adolescent and an adult, they are using social media commonly, there is some difference in the effect, because in the adolescent, the critical period for developing the frontal cortex, which handles the impulse control, at the same time the brain's reward system is hypersensitive, and that's why there is a surge of dopamine, and that's why the notification, the making highly addictive and harder the teens to self-regulate the as compared to the adults. And that's why if they get some notification, if they are not getting likes or if they are not getting comments, then they will definitely react in a very different way what the adults are giving their reactions, and this is the difference, correct? Now, is there any correlation between the screen time and depression? Yes. The higher the screen time, more is the chances of depression. Then there will be disturbed sleep, and that's why the whole cycle of that boy or girl will definitely, that will impact. then there is a comparison trap and it affects the self-esteem of the teenager. Means, for example, if my friend is getting the better reel, my friend is getting more likes, if my friend is getting more shares, if my friend is getting more subscriber, then these kind of comparisons or these kind of comparison traps, they are more than enough to create the depression in the adolescent. There are multiple positive sides of even social media. For example, to stay in touch with each other, to build up the new relationship, it can improve your communication skill. It is giving a lot of access to the different kind of information. It is providing you the different educational resources. Then you can explore your interest. For example, if if I do like the music or this painting, I can explore the different things, whatever is going in the whole universe. Then it can give me boost up to creative for my creation and for my self expressions. Then I can develop my own identity, which was very difficult without social media. I can build my own brand also. I can improve my social skill. Then I can get support from the other people who are away from me. I can connect with my friends who are far away from me. I can get support of different kind of networks. Or there are multiple positive aspects of the social media, but unfortunately the negative part is getting empowered over these negative this positive effects. There are multiple negative problems of the social media also. For example, the kids, they are getting cyber bullied or they are getting harassed. Then they are getting involved in many kind of bad things also, which just madam have already told. Then there can be phishing and there can be these scams also. Then your identity can be stolen, it can be used in a very different way. Then anybody can breach your data, there can be privacy issues. Then the malware or malicious links can be sent to your softwares and they can hack your data also. Then you can have problems in your social engineering. You can be facing the false news or bad or wrong information also. Then it can your reputation can be damaged and cyber stalking can be there. So there are so many good aspects also, so there are so many bad aspects also. As well as these
என்ன பண்ணா
adolescents, they are
இன்னைக்கு
influenced.
விடாச்சி நீங்கள் கொடுத்துட்டு நீங்க வீட்டுக்கு
Hello.
போய்க்கோங்க நான் சொன்ன symptoms
Yes, please make the madam sign. Okay. Again, the social media, it is influencing the sexual identity of these boys and girls also. For example, when there was no social media, then there was a particular age of the boys and girls to know about the sexuality, who themselves are. But in while using this social media, the boys or the girls, they can get the information quite earlier and they can get confused or they can be pressurized to adopt or to label prematurely. Then there is something called as a sexting. Sexting is nothing but the sexual exchange of the sexual things amongst the different kind of male female or male male or female female also. Nowadays it is very common. Sexting is sending or receiving or forwarding the sexually exploited messages or photographs or videos primarily between the mobile phones. And it may also include the use of computer or many other digital devices also. Sharing sexually explicit images or messages can have serious consequences, including the legal ramifications and reputation damage also. Nowadays it is very common. Again, it is one of the very common reason why the relation between the boys and girls, it is increasing day by day. Because when the social media was not there, and if any boy or a girl, they want to establish the love relation or different kind of relation with the other person, then it was only one way out, and that was physical in front of each other. And that was very difficult. But nowadays, just by sitting in your room at a 1 a.m. or 12 a.m., anybody can send any kind of message to any boy or a girl. And there will be only two effect, either yes or no. If they say yes, then it's okay. If they say no, then even I can say that I don't know who forwarded message from my phone. Maybe my friend have messaged you like that. And that's why the level of daring of these boys and girls, it is increasing day by day, and sexting is on its very high rise. Now there is one important question from my side. Is the effect of social media in the teens is the cause for early menarche or early puberty? I asked this question even in the Foxy and Amogs conferences also. So many people, they were saying that yes, it may be one of the reason. Definitely the reasons are very different. For example, the endocrinal disruptors or utility or the environmental issues, and many other reasons are there for early puberty. But this is very good subject for the people who want to do research, that is there any effect of social media on the earlier menarche or early puberty, not only early puberty in the girls but as well as in the boys. So opinion is again expected from everyone. Then hypersexualism is a very problem, and because of very easy availability of the pornography on the sexual on the social media, most of the boys and girls, they are getting engaged and getting involved in the sexual relationship at a very minor age group. And in metro cities, the involvement of the boys and the girls in the sexual activity is reduced up to 13 years of the age. It is really worrisome, but unfortunately it's true. There are many studies and data who gave the data which are telling that the common or the average age of the boys and girls to get involved in the sexual activity is 13, and to find a virgin boy or a girl at the age of 18 or at the age of marriage, it will be very difficult very soon. And because of this early sexual this involvement, these boys or girls, they are the girls, they are getting involved in the teenage pregnancies, then unsafe abortions, then complications of abortion, then sexually transmitted diseases, then familial and social issues, because they are getting depressed, they are getting out of their studies, then academic losses, and the most important thing is, because of these kind of experiences and because of these kind of misconception regarding the sexual activities, 90% of the couples, they must be getting the issues in their sexual life, because the real married sexual life is totally different than what they are getting in the pornography, or whatever knowledge they are getting in the social media. This is my own thinking. Now, is there any link between the social media use and earlier sexual? Yeah, yes, I have already told you that the hyper networkers spending more than 3 hours on the social sites, they are they are getting engaged in the high risk sexual behaviors, and the peer pressure is the commonest reason why they are getting engaged, because everybody knows that to get attracted towards the opposite sex or to get yourself engaged in the sexual activity is not good thing, but the negative peer pressure or the peer pressure, that is one of the factors which is making them to get involved. And impact of the cyberbullying and this teen sense safety, it is really a very important point, because initially when it was not the social media, the traditional bullying was not 24/7, but now it is 24/7. At any second of your life you can get cyberbullied, correct? And if such kind of things they get viral, then that boy or a girl, they will feel like the life is very miserable and they will be literally devastated. So my take home message for the today's talk is, the self implementation is very important. To advise any adolescent for the bad things, or to stop the use of this social media is very easy, but I think the self discipline by the parents, by the teachers, and by all the adults, that is more important and that is more impactful for the adolescents. Then comes the digital hygiene. Then you should teach your kids about the digital hygiene management and the monitoring of the social media use by the parents without breaking the trust of your adolescent. That is again a very important thing. So this is never ending subject. There are other multiple aspects for this subject, but we are short of time, and that's why I think I should stop there, and I am literally waiting for the inputs by my both chairpersons. Over to you, ma'am.
Yeah.
Thank you, Girish, sir, for that extremely wonderful, elaborate, and exhaustive information on social media impact. And it was really,
Prerna,
really
can we listen
quite
Lata
an
madam?
informative.
Yeah, I
Prerna,
want
Prerna,
to
Yes, ma'am.
I
Prerna.
want to
Yes, ma'am.
bring in some points. I think Dr.
Yeah, Lata madam.
Girish, you have brought in extensively lot of things. I'm being the warden, I always, tell the parents, first thing I tell them, now actually there's a very good connect between social, like you said, no mobile phones, and connectivity is so good. So I tell them, you have a good opportunity to monitor your children, because they're just out of, school, and because we see a lot of students getting depressed because they don't talk to each other, always on the mobile phones. I mean, I get very scared when I get a call from the hostel. The first thing is what they have done to themselves, because Earlier, we were all like together in the common room. It's not there. I mean, that's a big thing. I also wonder whether this is increasingly the reason for autism, which we are seeing,
Yeah,
because we've never heard of autism in our childhood. But
very
now,
true.
there are serials, there are movies on autism. It's like very scary. But yeah, there are good side and bad side. Ultimately, parents have a major role to play in this. Easy way out for parents is, I mean, when a child tries, give off a mobile phone so that he gets engaged, and that's
Babysitter. It is nowadays babysitter.
everyone. I mean, yeah, as you said, babysitter, whoever is taking care of the child, except grandparents, I suppose. But
Yes, yes.
grandparents are the best ones to take care of children. But these problems are there. Solutions are very difficult to get for each, because you have brought out almost everything. So I think these things we all also have, maybe in schools and even medical colleges,
அவங்களுக்கு
we
நல்ல
should.
கிறிஸ்டி தெளிவா
Yeah.
எழுது
Another thing I
ஃபைல்
was about to tell is, even in schools,
அதுல
the
பேப்பர் ஃபுல்
children are
ஒரு இது ஹிஸ்டரி எழுது கரெக்டா இந்த பையன் காலையில எவ்வளவு கொடுத்தாங்க இந்த சுவிசர் கேஸ்
Host, can you?
Amala madam, mute பண்ணுங்க madam.
ஃபைல் போட்டுரு
Amala madam,
Amala
please
madam.
mute yourself.
இது
Dr.
இன்ஃபர்டிலிட்டி
Amala, mute please.
Lata madam, please. Lata madam, unmute yourself.
Yeah,
Again.
yeah.
Yes.
Please.
So these are the problems. Like I think we have a big responsibility towards adolescents, and as you said, I was also thinking in the same terms about puberty, menarche, and whether it is anyway
Madam, but I would
related to.
say one of the very common reason for PCOS is definitely social media.
Yeah.
Because I mean, there are a lot of changes in their food kind of. I mean, they're consuming a lot of food while watching these social
Yes,
media.
yes.
No? So the girl who can have
No physical
two
activity.
rotis, they are consuming 3, 4, 5 rotis, and they are not even aware of.
Unfortunately, most of the schools don't even have a playground, nothing except,
Right.
whatever studies and these social media things which go on. But nice, Dr. Girish, we could
Thank you, ma'am.
interact
Thank you a
and
lot.
brought out a lot of things. And again, as I said, there are a lot of studies to do on this, and
Yes.
also big responsibility as doctors, as teachers towards these children. And in fact, even to ourselves, I also spend a lot of time on social media, unfortunately. But then, yeah, thank you. On to.
Yeah. So my last take home for today's talk is, after becoming a chairperson of Sexual Health Committee, I would request Dr. Madan Kamble to. I mean, he will have 3 years in his hand, and same is the request to Dr. Prerna after taking this Young Talent Promotion Committee. You can do some research on this social media and children. I mean, you can do some research on health, or I mean, on their health, or on their something research you can do. So please think of this also.
Yes, sir.
Multi-center trials.
Definitely.
Yeah.
Yes, definitely, sir. This is the topic to be really looked into, and your talk was really fantastic. You have covered everything, and Lata ma'am, your inputs were very nice. Yes.
Thank you.
Yes, thank you so much, Chairperson,
Thank you all.
and thank you, Girish bhai. Yes, thank you. Now we will move on to the panel. Lata ma'am, will you please join the panel? Please.
I don't know
Please
what
join the panel.
inputs I'll give.
We all are there. If you
Yeah.
give us a chance,
Yeah.
we can give our input.
Okay, sure.
Okay,
But don't
okay.
expect me to give any wonderful inputs. Let's see.
No.
Sure. Yeah. Okay.
Try
Okay.
also say
Yes.
back, please, for the panel.
Yeah, sure.
Prerna, over to you. Prerna, over to you. You were speaking something and I just stopped you. Please.
You said
No,
stay back.
I was just saying that your talk was quite elaborate, extensive, and quite informative. And
Thank you.
and always a treat to hear you speak. And none other than you would have been the best choice for this adolescent social media topic. And we have seen you last in AICOG Delhi also. The way you had cruised around the entire session of the Adolescent Health Committee workshop, and the entire crowd was stumped by your presentation on this particular and such a sensitive topic. You took care of it. Every nook and corner of the topic has been discussed. Thank you for being there.
Thank you. Thanks a lot, Prerna.
He is the master now in this. Okay. Mm.
But all of us should agree, thanks to social media, we are all getting connected, getting known to each other. That is the
Yeah.
biggest advantage of sitting so far from each other yet connected.
Very true, ma'am. Very true.
அதனால தெரியல நான் எனக்குள்ள பண்ணி பார்த்தேன் எனக்கு நான் ஸ்கேன் பண்ணேன் இப்படி உட்கார்ல ஸ்கேன் எனக்கு நான் ஸ்கேன் கரெக்டா வரும்
Okay.
அவருக்கு
Let us-
இதாக மாட்டேங்குதா Dr. Madan, maybe you can unmute everyone and unmute only the panelists.
Darshan,
நம்பருமே அவருக்கு வர மாட்டேங்குது
Yes, sir. Yes, sir.
yeah, please mute others.
Done, done.
Yeah. Okay. Today we are discussing about the psychosexual crisis. What are the psychosexual problems in the midlife? Yeah, this is the particularly and specifically chosen topic for the discussion because in day to day we encounter so much of problems which are happening in the midlife. Is it full screen now? Yeah. So for this,
So it's not full. No, now it's full screen. Yeah.
yeah. For this panel, I welcome the experts, Dr. Umayal ma'am, Dr. Sundar sir. I think they are busy; they could not join. I welcome Sampath ma'am as expert for this session. And, I welcome the panelists, Dr. Vijitra ma'am, Secretary Karur, Dr. Vijay Prabha ma'am, Secretary Trichy Society, Dr. Purnima, President of Erode Society, Dr. Chandra Ponuswamy ma'am, who is the President of Namakkal Society, Dr. Selvarani, Secretary of Dindigul Society, Dr. Vani Madhavan from Secretary Erode Society, Dr. Hemlata, and I welcome Lata ma'am also. And I request Rekha ma'am also to join and everyone to join, including Girish sir. Okay. We all know what is the period of midlife, and we also know what are the challenges that the people face during this crisis. It is generally a shift in the ages of 40 to 60, and this is the halfway point actually, and people tend to re-evaluate their lives and confront their own morality. And for some, this becomes a significant issue that affects their relationships and careers. So, this crisis can affect the self-concept, self-confidence, and this can lead to many changes. That is, changes in the moods, behaviors, emotions, and also the relationships as people cope up with the transition to midlife. That's why this transition is very much important to understand the problems and to solve. At the same time, we should look for the sexual function. Is there any effect on the sexual function? Are there any problems in the interpersonal relations, or normal sexual function is disturbed or not? Because this is affecting the quality of life for the couple. Sexual function is closely correlated with overall well-being and the relationship satisfaction. And looking to the statistics, minimum 45% of midlife women have sexual problems, and 15% have a sexual problem that causes significant personal distress. And that is why this is totally under-recognized, and at the same time, it is under-treated by us, that is the healthcare providers. That is why we have to learn something about this, and we have to aware regarding these issues. Then let us understand what is the normal sexual function. It is the complex interplay of physical, emotional, and psychological factors between the couple or partner. This is the simple definition. And what is meant by sexual response cycle? That it is nothing but the fundamental interplay between the mind and body. There are 4 phases of sexual response cycle. First is desire, arousal, intromission, and orgasm. These are the main 4 phases. And these female sexual dysfunctions are divided depending upon these 4 phases of sexual response cycle. That is related to desire, related to arousal, related to orgasm, and related to sexual pain. And these are the 4 main types of sexual disorders. This is the Master and Johnson's linear model of sexual response. And This is the circular model, that is the Rosemary Basson's non-linear model. And this is based on the intimacy. We will not go into the details of this. We will focus mainly on the practical aspects. And my first question to the panelists will be, which factors affect this sexual function? This is a general question. Anyone can take this question. Which factors affect this sexual function of an individual?
So, good evening, I am Dr. Chandra Ponnusamy,
Yes, ma'am.
from Namakkal, and thank you for the opportunity given. And instantly, I am being the chairperson of Midlife Committee of Tamil Nadu, TN Fox.
Wow, great.
Yeah.
Thank you.
Then, actually, midlife is the stage, as you said, it is the stage by the time they are, I mean, actually, they really know the life. They begin their life at that stage only, because they had their children, everybody, and they the job, everybody. Once by the time 40 years only, they settle down. But by the time they are going into this perimenopausal group, problems and social problems and the family problems, so many they have to encounter, both men and women, they encounter all these problems. So mainly these biologic factors of perimenopause and other things like whether they are comorbidity, BP, hypertension, and diabetes, everything, they come across all these start at this age group only. And from family, we have family members, students, and their children. They are at the stage of school finishing, college going, and this midlife is sandwiched between the children and their parents and in-laws. So emotional factors also, they come across many psychosocial problems and all. So this is the concern many of midlife.
Yes, ma'am. You're rightly. Lata ma'am, do you want to add
Yeah,
anything?
I just wonder whether people do feel ashamed after the age of 40 years that, this kind of sexual life is not for us, especially for women in our country. So I feel, I don't know, I come across some of these patients who feel, no, na idella panna I mean, I don't do all these things. We have left it long back. So I don't know whether those kind of, thoughts come to women at this age that would be affecting his sexual life.
Yes, I think interpersonal factors are very much important also, because if there are any conflicts or any myths regarding this, that menopause is the pause of the sexual life, and there are also so many other factors which can create these misunderstandings or conflicts, or uh, there may be loss or gain of a partner, or aging related problems may be there. For example, this biological factors like GSM, vulvovaginal atrophy, pain during sexual intercourse, reduced desire. These are the very common problems. uh, so there, our roles comes there to remove their myths and create the positive environment, and so that they can improve the interpersonal relations.
As Dr.
And
Lata correctly said, they don't come out with all these problems, and discussing this with the doctor itself, they feel as if they are guilty, and we will think, because you are more oriented towards sexual function and all, so they feel guilty. That is one main problem, and they come out with many other symptoms like body ache. They'll indirect problems they'll tell, but not the exact problem.
yes, many times we have to take the lead to ask them, is there any problem in sexual relations? And at the same time, at this age, they might be having some medical issues, and for that, uh, they are on drugs also. Yeah, these are the common symptoms of menopause. We all know cyclical changes are there, hot flushes, tiredness, loss of libido is very important. Anxiety, sleep disorders are there, loss of memory, and physical problems like dry vagina that causing the discomfort in intercourse. Yes, how the sexual dysfunction affect the quality of life? Yes. Yes. Anyone can take this.
So definitely it will be depression, and they will have other factors, infertility, and so interpersonal relationship will be strained.
Yes, there is low self-esteem, there is frustration many times, anxiety, depression. These problems are coming in the perimenopausal age. Irritability is there, marital disharmony may be there, and all this causes the disturbance in the interpersonal relations. And there may be
I
some
just
quarreling, arguments. Infertility is also there. Sometimes it may go up to the divorce if the relations are stretched so much. And second important aspect of this female sexual dysfunction, which is affecting on male also, that cannot be missed, because in these cases, the husband may have premature ejaculation or erectile dysfunction, or the case may go up to the divorce or extramarital relations also. So, collectively, we can say that these dysfunctions are affecting badly on the quality of life of not only a female but the entire the couple. Girish bhai, would you like to add something?
Then actually I was typing one message that I need to go because I received just a call from my hospital. One patient is
Okay,
about to deliver. Okay.
okay, sir. It's
Bye
okay.
bye.
Thank you so much, sir. Yeah.
Yeah.
Madan, I just want to, give one anecdote which happened when I was a senior resident. We had a 60-year woman, 60 years of age, who had prolapse and she just chopped it. You won't believe there was bowel protruding it. The reason she has given is my husband wanted me to have sexual intercourse at this age. How dare he? You won't believe these were the things because of which, I mean, the whole night we sat and repeated. Luckily, she went home. This was published also. So those thoughts, this was not now, almost 30, 25, 26 years back. But these are the things which, affect women. And yeah, as you said, even at the age of 60, people can still go in for divorce because of, incompatibility between women and husband and wife. That's true.
Yeah. Yeah, that is why
Most of the
counseling is.
time, Madan, they don't come out with the problem. That
Yeah.
is the many people will be having. They don't come and tell. That is the reason the other problems like depression, other divorce, everything happens.
And
Okay,
yeah,
Madan.
as Lata ma'am has stated, this is the real scenario. Still, the situation is not improving
Not
much more
something.
because there are really there are such problems in the family. Yes. This is the classification of female sexual dysfunctions. The old classification was as per the DSM-4 criteria. As per this DSM-4 criteria, female sexual dysfunctions were divided into 4 main types: sexual desire disorders, arousal disorders, orgasmic disorders, and sexual pain disorders. Then, with changes done in the DSM-5 criteria, these are the as per the newer classification. These desire and arousal disorders are clubbed together in sexual interest arousal disorder. Orgasmic disorder is kept as it is, and sexual pain disorders where dyspareunia and vaginismus, these are clubbed into a different terminology, genitopelvic pain penetration disorder. So these are the 3 main types of FSD. The female sexual interest arousal disorder, it is nothing but the persistent or recurrent loss of desire in the sexual activity, sexual thoughts, and sexual stimulation. And there is also increased stress in the woman. This is also a common disorder as far as the not even in the perimenopausal, but youngsters are also suffering from this. Then let us see what are the criteria of female sexual interest arousal disorder. Yes, these are the 6 criteria. Yes, anyone can have. Dr. Purnima. Okay.
Definitely not aware of this.
Okay.
I just went through the presentation.
Yes, Chandra ma'am.
Yes, yeah.
Yes, you
Actually,
can take.
here I want to tell one of my patient came for infertility, 10 years, married 10 years. So while I
Yeah.
was examining,
Not
yeah, she had severe vaginismus. So
Okay.
Then I counseled her and I said everything, medically also, the dilatation, everything I did. Now she is blessed with a male child, 3 years old. Now they are very happy, and every time when they will see me, they tell, you have என்னோட வாழ்க்கையில
விளக்கேத்தி வச்சீங்க.
விளக்கேத்திட்டீங்கன்னுட்டு. So mainly arousal disorder, usually because many times due to lack of awareness and our brought up also.
Very true, ma'am.
Brought up because you have to keep away from men folk and everything. We were taught, and once you get married, suddenly all of a sudden we cannot get arousal. Otherwise, when the male partner does everything, but otherwise spontaneous desire. Maybe this generation they are all coming and telling, I don't get a desire and I don't arouse anything. They are coming with a complaint. But as far as our generation concerned, we don't and we don't think that it is a problem also. It's actually our loss of awareness was not there, because it was taught as a taboo, all these things. You agree, Purnima? We were.
Yes, yes,
Yes.
ma'am. Yes, ma'am.
Yes.
Sir, I'd like to
But,
add.
Yes, ma'am.
Yeah, see, today we are seeing both ends of the spectrum. There's one end which is
Yes,
overexposed,
yes.
and there's
Yes.
one end which is still not aware or not acknowledging or ignorance. And there's, like Madam said, the environment in which they are brought up, where they're completely cordoned off, and men and women don't interact, and they don't see their parents in that manner, or they don't see a cordial relationship between a man and a wife, or a boy and a girl. So it's always thought that to interact with a boy would be, and other things would be like any sexual assault or child sexual abuse, which has psychologically affected these girls. So that actually gives them a lot of inhibition. So when we sit with them for history and then understand why they are not interested in sex, and when the husbands complain, I think spending a little bit of time and understanding where the pain comes from, is it some previous trauma, or the exposure, or the family situation, or any broken families where they've had exposure for fathers having repeated relationships, and that has caused trauma. So we see these kind of issues in the family which affects the girl. So I think all these psychological support and awareness is an important part of our treatment processes in these women.
Yes, I completely agree with you, ma'am, because these are the real scenarios in many families that are affecting the adolescents. They are
Correct.
watching everything and they're undergoing through that psychological trauma day by day. What is happening in their home. And second thing is overuse of social media. Now we are seeing the extremes of these situations, because
Our generation is one where we see wide spectrums of both this side and the other side.
Current generation is far ahead.
Yes, exactly.
With the
So
overuse
we
of
being close to Bangalore, no, so we see a lot of these IT people who actually
Yes.
don't want to have physical sex. They're ready to see movies and things like that together. And otherwise, the exposure with all these toys and other things. So even the girls are so, they want a different experience. So they're actually exploring various things. And when they come up, we think sometimes we as doctors itself feel it's absurd. But I think they're all getting too diverted with these things. So the idea of sex and family life and other things have changed in many of these young women.
Yeah,
No,
I
you have
agree with
rightly
you,
pointed out.
Dr.
This,
Rekha.
Yeah.
Yeah, I agree with you. Many times you would have come across such type of patients. They are married for quite some years, and what they are coming and telling, for the past 3 months, 4 months only we are trying. I don't understand why they are differing this, whether they have the desire or they postponed all these things, but they are telling like that only. Only for the past 6 months we are trying, because those days when the men, they don't get the acceptance or willingness from female, especially in the lower group. No, now they compel them, and they does the act everything every time. So they become pregnant also. But nowadays these men folk, they are hesitant to have sex without the girl's permission, or they both want to interact with each other, whether we'll have sex with the, because whether desire for men also has come down, I feel, in that way. So this
as far as this IT people
Yes,
are
but
concerned,
yeah.
yes, there are so many problems. Many females, they both are working, and there is pregnancy phobia. Many females don't want pregnancy. That's why they doesn't have the vaginal intercourse. Literally, they don't allow the male partner also, and they are the both husband and wife are uh, used to their this thing, and uh, many couples demand IVF pregnancy due to this. They don't want vaginal intercourse. Second thing, they don't want any responsibilities, family responsibilities, kids responsibilities. That's why she don't want to become pregnant. These are, and again, one issue is there, lack of sexuality education. Although they are very highly educated, but sexuality education in which they are lacking.
Madan, I want to say something here. I think there are certain religions where before marriage, when after they engage or something, they give counseling to the, boy and the girl regarding the sexual life and family life and all that. I think maybe now those days it was not important. Everyone knew the moment you're married, like in Tamil Nadu, they expect the periods to be missed the moment the couple get married. Every day we have these problems. But what I've seen in certain, as Vidya and all were telling, children, people, as you were telling, people don't want to have sexual intercourse and this thing. But all these, I think, counseling by parents, by everyone, without having any inhibitions, is becoming mandatory. Though these people know everything through social media, but things are very different. I mean, there are too many things to discuss and too
Yes.
wide problems.
Very big problem that what we are seeing. Okay. To make any diagnosis of a sexual disorder, three things are very important. That females should experience this disorder at least 75 to 100% of the time. Second thing, the period of duration should be at least 6 months, and this dysfunction should have caused this significant distress between them. Then how to evaluate for these female sexual dysfunctions? There is one Placid model which is used to for the evaluation of these dysfunctions. Placid means P is for the permission, then limited information, S for specific suggestions, and IT is the intensive therapy. Then how to recognize the underlying conditions which are contributing to this reduced desire. That we have to ask the detailed history about for this. For any sexual dysfunction, we have to go into the details. We have to ask about any major relationship or physical issues. Then we can solicit more detailed information from the patients. For that, we have to ask about the onset, duration, any behavioral adaptation is there, or any evidence of activities. Then we have to ask for the level of the distress. Then, as far as the history is concerned, we have to ask the details of the medical history. Means obstetric history, gynecological history, any diseases, any medications, and comorbid conditions like endocrine or neurological or cardiovascular diseases, and any psychiatric disorders or the medications, and use of prescription and over-the-counter medications, because this may affect the normal sexual function. These are the defining criteria and types of female orgasmic disorders. Yeah, same like this. The diagnosis of orgasmic disorder is clinical based and as per the DSM-5. Orgasmic disorder means there is delayed, infrequent, or absent orgasm, or markedly decreased intensity of orgasm after a normal sexual arousal phase, or almost all the occasions of sexual activity. And again, the rest of the criteria are simple, same. That is, there should be interpersonal distress, and the symptoms must be more than 6 months. Then these are the types of orgasmic dysfunction, that is primary anorgasmia, secondary anorgasmia. Primary means they never had orgasm, and secondary means previously they used to have orgasm, but currently there is difficulty. And situational means only in certain circumstances they can feel the orgasm. For example, oral sex or masturbation or with certain partner only. And generalized anorgasmia means there is no orgasm in any situation or with any partner. Then I would like to know from the esteemed panelists, what are the possible causes of painful sexual act? Painful sexual act. What may be the causes?
Vaginismus.
Yes, dyspareunia and vaginismus are the two main types of sexual pain disorders. But what are the causes? For example, in dyspareunia.
Deep dyspareunia and endometriosis and adenomyosis.
Yes.
There are some organic causes also. It's not always
Yes, organic and
psychological causes.
non-organic. Yes.
Yeah, so some kind of, ulcers on the vulva or in fact malignancies, which are
Yes.
occurring quite early nowadays. So, or any trauma in the vagina.
Infections, trauma.
Especially after
Yes.
delivery.
Lubrication relation, dry vagina.
Dry vagina, yeah.
Or if there is any pelvic pathology or any past history of
Yeah.
surgeries, pelvic surgeries, any LSCS, episiotomy, or any laparotomy, any laparoscopy. And third is the emotional factor.
Yeah.
Yeah. Emotional factors, psychological issues, stress, or past history of sexual abuse. This is the vaginismus. Vaginismus, the recent definition, international definition completed 2005, which states that there is persistent or recurrent difficulty of the woman to allow the vaginal entry of a penis, a finger, or any object, despite the woman's expressed wish to do so. Ma'am has just shared one case of vaginismus. There will be so many cases of unconsummated marriage due to the vaginismus. This is the grading of vaginismus from grade 1 to grade 5. Grade 1 and 2 are mild. Grade 3, 4, and 5 are severe. In grade 5, what happens? This grade was later added by PASIC. In this, the patients manifest, there are visceral responses such as crying, shaking, trembling, sweating, hyperventilating, and also she may experience the palpitations or nausea, vomiting, etc. She may go unconscious, or she may want to jump off the table, or may attack on the doctor. This is the grade 5 stage of the vaginismus. Then how to evaluate any case of female sexual dysfunction? How to evaluate? Yes, anyone can take.
From
Yes,
detailed
Rekha ma'am,
history-
Lata ma'am. Yes.
Detailed history. And mainly they, as you said earlier, they don't come out. Few people only come out with, or the parents bring them. Because usually this mother asks that girl whether you had a relationship and all. In many families it goes on like that, and they bring their children to the OP that whether they have consummated or things, please find out and tell us. They come out, and anything else also, because a period of infertility, then from that only we can find out whether they had a consummation or not. Then again, depressed. They are very much depressed, and sometimes they'll ask for separation, diversion or separation. So from indirect history, we can bring out these problems. And sometimes when you interact with the husband, he will definitely give, because she doesn't allow, and he will be having, she will tell that she is having premature ejaculation, or but she has not got any orgasm, anything like that. Even before that, the act is over, something like the complaints they will be giving.
Yes, as we are daily dealing with infertility patients, many times these cases present before us as a case of infertility. Or then when we go into the details, then we do understand that there is unconsummated marriage in many cases. Then we have to dig further deep. But there is no option for history. We have to have the detailed sexual history. We have to learn about this, how to take a sexual history. Each and every gynecologist should know. Because in sexual history, we must ask where we should start the interaction. Then and then the couple will open up. Otherwise, they will just come for the treatment of infertility. And many times, if we are a busy practitioner, we just give cysteine, letrozole, and everything, and we will call her for ovulation study. But we have to first ask, is there any problem in having sex? Then and then they will open. Many times, females first open that there is problem. Doctor, there is problem. The problem may be on male side of male partner or female partner. Detailed history of any difficulties, change of multiple partners, change of high risk behaviors that should be asked. Ask about the medical history, any medical diseases may be diagnosed or undiagnosed. There may be chronic or psychiatric illnesses. They may be on any drugs previously or might have undergone any surgeries, medications. And always ask about the obstetric and gynecological history.
So
Yes.
I think, most of us in the clinic, when they come, we do history initially and everything. And vaginal examination per speculum and or a transvaginal ultrasound, if we are able to do that, and then we will know whether they are having a sexual contact or no. Per vaginal examination is so many times missed in the OPDs. I've seen quite a few files where they've not had per speculum or a vaginal examination, and when they come and we see basic minimal intervention, and I think they're sorted. So I think this is something that all of us have to compulsorily do, and examination for the male also. So they also have to be examined in the OPD.
You're right, ma'am, because current generation of gynecologists is not doing PS and PV examinations. They are totally dependent on the transvaginal probe and this ultrasound. Each and every patient, they put a probe and just explain the patient.
I don't think they're seeing patients even without an ultrasound report. You come with
this
ultrasound
is
report,
happening.
then you enter the clinic.
Yeah.
The scenario.
I mean, even the fundal grips are not done. I mean, if you see their case sheets and things like that, per abdominal examination, fundal height, nothing will be mentioned actually.
So clinical examination is
new generation, this team like, practitioners are even managing eclampsia, ma'am, in our area. They just refer, if they get an eclamptic patient, they just refer to medical college.
Sir, one more addition, coital frequency in the history we must ask. Frequency.
Yeah, frequency.
Yeah.
At the same time, we have to educate them about which are the days of ovulation period, what is the ovulation period, and about the menstrual cycle. That's our responsibility is to give them some education and everything about the sexual history. And as far as the lab investigations are concerned, if we are in doubt or something, we can have the hormone levels done, LH, FHS, prolactin, thyroid hormones, or if needed, testosterone also in case of low desire. Some modalities, ultrasound, CT, or any, if we are suspecting any anatomical abnormalities, we can go for CT, MRI also. But basic is the pelvic examination. Let us move to the, yes.
I can take this.
Yeah, please, Prerna.
So cruising through this important panel, which has been really taken well by all our esteemed panelists, just let us discuss on this. What effects will menopause have on sex life? Any one of our esteemed panelists can take this up.
I think most important is disinterest, which happens with menopausal women in sexual life, and hormones also definitely play a role for this. That's what I feel. Yeah. Libido, loss of libido. After the age of 40, I think it's slowly the sexual desire definitely comes down in women, irrespective of what they are.
Yes.
Yes, lower sex drive.
They also get diverted, especially with the family commitments,
Grandchildren.
professional commitments, and other things. And this is the last priority. But it does affect their interpersonal relationships with their husband. And we do see couples who are a little disturbed because of this. And when we counsel them and we tell the women that it is part of life that has to continue, and it's not like an end to once they've had most of the girls, after they've had a child, or if we've done tubectomy or family planning, automatically they start getting more involved with the kids and show disinterest with the husband. This is one of the reasons for polygamy and other things. And we do see in the peripheries that these husbands complain, they come and bring them and for counseling. And the women are little reluctant, but I think hormonal changes, mood swings, the male partner also has to understand, and the female also has to equip herself to become better sexually active.
Having said that, I had a different this thing with few patients where women were interested, but the male absolutely said no. Like,
Yes,
it's not
yes.
that women do not have sexual desire, the other way around. Most of the times this is true. But I mean, I didn't really know what to counsel. The husband would refuse to come for counseling. But the girl, she says, my husband is not talking to me, no sexual relationship. I feel like committing suicide. And so this also happens.
Yes,
This is also,
Yes.
yes, correct, ma'am.
Yes.
In sometimes what happens after the 2-3 kids or after the age of 35, there may be some
Then it becomes
infidelity issues.
laxity.
Infidelity issue. He might have some relations outside also. That is why he is less interested in the wife.
No,
That
the
may be
other
one
way
of the,
around also,
that
I
may be one
feel.
of the reason.
Maybe after vaginal deliveries, vagina becomes lax, and that
Yeah,
may not create interest in a man.
that
So,
is
I mean,
why.
that may be
Why
one of the reasons.
cosmetic gynecology is coming up? No.
Yes, yes. But what I would suggest about the cosmetic gynecology, proper communication and counseling is very much
Yeah.
necessary, because they should know what are the options. If there is lax vagina, it can
Yeah.
be treated well with non-surgical techniques also, or with surgical vaginoplasty. But the problem can be solved. This has to be
Yeah.
counseled with them.
Consulted.
The problem will be solved.
And there
Yes.
should be
Madan,
proper
as you
communication.
tell,
One more thing.
Yes,
One more
ma'am.
thing.
Sampath, ma'am.
yes, as you tell, I will tell one different interesting case.
Yeah.
The couple married with 3 months, I think. This girl is having that animals, cat, 2 cats. So the husband is telling, don't bring the cat to the bedroom. But this girl is telling, I know the cat before husband. I can leave husband, not the cat. So these are all the situations now it is happening.
Ma'am,
So
we
both
have patients who
sides
say they want to be pet parents and they don't want children, madam. So,
so
yeah,
these
they
are all the
rather be pet
counseling.
parents.
History eliciting is very, very important nowadays.
One more thing in menopause is the empty nest syndrome. And because this is the phase where she has entered into the finish of her responsibilities, her children have grown up, and she is wanting more of closeness with her husband, but then she is not getting it. So even that is the point where she becomes psychologically disturbed. Very well taken by all our panelists. Can anyone take this on what measures can you advise to improve her sexual health during this time? As rightly said by Dr. Madan, counseling, love, care, and tender support. And Sampath ma'am has said that we need to take a proper history. And can we be more specific?
Women who have menopausal symptoms can be, I mean, only those can be, especially hot flushes and night sweats, can be advised to take a menopausal hormonal therapy that for some time that will definitely help, and maybe some antioxidants in the form of, amla or things like that.
Yes.
This will help other than the tender loving
This,
care and
yes, yes. This is the medical treatment, but non-medical treatment is
yeah, it's more
counseling.
important.
We
Yeah.
should encourage to remain active, physically active, with a good mood and good communication between the partners.
And maybe involve in something which they like.
Actually,
like
they should take time for each other.
yes.
They should take time for each other, go outside, enjoy the vacations. Then and then their communication will be better, interpersonal relation will be better, then there is no need of any desire and everything. Everything will be smooth. Allow some time, practice good pelvic floor exercises, and these are the general advices to avoid the products that irritate the vagina. Then we know there is vulvovaginal atrophy due to the hormonal changes. Then that can be treated with the medicines like estrogen supplements for the vaginal dryness and dyspareunia. Vaginal moisturizers and lubricants. These are the first line therapies that every gynecologist can use for the symptomatic relief of painful sex, because many times they have vaginal dryness. Yes, many times these are the woman's top priorities for the general well-being of both. Emotional reactions during love making, attractiveness of one's partner, physical response to love making, frequency of sexual activity with one's partner, partner's sensitivity, and one's own and partner's state of health. These are the general women's priorities. Yes. So that was the best panel, best discussion. I think we should stop here because this topic is never ending. It can take 1 hour more.
Yeah.
Yes. I'm thankful to all the panelists. There were good inputs by all. Very nice inputs and sharing of experiences.
So Madan, we can have one take-home message from each of the panelists, including
yes.
we have Chitra also.
Yeah, requesting every panelist to give a single sentence message. All.
I mean, don't worry, be happy. Be happy in life, everything will go good. That's what I say.
Yes.
Don't keep thinking you have problems. Everyone has problems on earth. So we have to be over and above all that.
Yes, Chandra ma'am.
I usually advise the women to prioritize themselves, take care of their health, and take care of themselves in such a way that they don't feel distracted or the husband doesn't feel distracted too. I usually tell them regularly because I think that's one way you have to. There's a maintenance for everything, just like our car, like everything else. There's a maintenance therapy for everything. So relationships also need to be mended and maintained. So put the effort to maintain the relationship is what I would advise them.
Very correct.
Yes,
Purnima?
proper communication between the partners is very, very essential, and they have to discuss their own problems and they have to find the solution among themselves. It's better.
Yes. Purnima ma'am?
Thank you, sir, for giving this opportunity. And definitely, we have to live a stress-free life as we are all being bombarded with stress. So we have to advise our patients the same things.
Yes. Okay. Your Sampath ma'am is there?
Sir.
Okay.
Sir, I wish you the election to win and for the chairperson and Dr. Pranna also, and our own Sampath madam for the president to be elected, and wish you all the best for three of you.
Yes, Sampath ma'am. Sampath ma'am has left. Huh? Okay. Yes, thank you so much once again. Wish you Sampath ma'am also for the elections, upcoming elections as president. And we both, on behalf of me and Prerna, we requesting all the presidents and secretaries to kindly vote and support for the upcoming elections. I'm going for Sexual Health Committee and Prerna is going for YTP Committee of Proxy.
Yes.
Thank you and all the very best to both of you.
Thank you so much.
Thank you, sir. Thank you.
Yeah, we enjoyed the panel.
Thank you all. Thank you so much for this opportunity.
Thank you, ma'am. Thank you.
Yeah. Yes. Thank you. Good night.
Good night.
Yes.